by again my well-wisher and one of the scientific committee members, Dr. Srinivasan sir. And then the other case is given by Dr. Vivek sir. In fact, it is a PG of Dr. Vivek sir. So from Sri Satya Sai Medical College, where sir was the medical superintendent earlier. So thank you, Vivek sir, and thank you, Dr. Lalit Kumar sir, for giving the PG for today's class.
Okay.
So with that in mind, I
And
will
for
request. I will request the Robin. You can start your presentation, Robin.
Chetan, you could call and tell him, sir.
Sir, he is going second call, sir. I will arrange, sir.
Yes, sir.
Hello. Hello.
Madam, vanakkam, namaskaram.
Robin,
Yes,
start.
sir. Can I
Start.
Please.
Start.
So, very good evening to all the faculties across India. I'm very thankful for Dr. Vivekanand sir and my professor and HOD Dr. Lalit sir for giving me the opportunity to present the case of groin swelling. So, I'm Dr. Robin Samuel, final year postgraduate from Satya Sai Medical College. I'll go on with the presentation. A 60-year-old male patient who's a farmer by occupation residing at Temanjeri present to OPD with chief complaints of swelling over the left groin for past 3 months. History of presenting illness. Patient was apparently normal 3 months back, after which he noticed a swelling of about the size of a lemon over the left inguinal region, which was insidious in onset and gradually progressed to attain the present size, reaching up to the scrotum. Swelling increases in size on walking, standing, and straining. Swelling disappears spontaneously on lying down. The swelling is not associated with pain in the groin region. No history of fever, vomiting, or distension of abdomen. No history of difficulty in defecation or urination. No history of thinning of stream, hesitancy, increased frequency or urgency of urine. No history of constipation, chronic cough, or trauma. No history of any other abdominal swelling. Moving on to past history, patient is not a known case of pulmonary tuberculosis, diabetes mellitus, systemic hypertension, bronchial asthma, or epilepsy. No history of similar complaints in the past. No history of any drug intake for a longer period of time. No history of any previous surgery done. Moving on to personal history, patient consumes non-vegetarian diet, normal bowel and bladder habits, normal sleep pattern, does not consume alcohol or tobacco in any form. Family history, patient is married with 2 children, no history of similar complaints in any family members.
Hello.
My summary, a 60-year-old male presented with a reducible swelling in the left inguinal region for past 3 months. Swelling increases on straining and disappears spontaneously on laying down with no associated pain.
Patient has no urinary symptoms? Sorry, I missed
No,
it
ma'am.
out. No urinary symptoms.
Yes,
what is the history you asked for urinary symptoms?
I asked about hesitancy, any increased frequency or incomplete voiding.
Okay. Did you ask for nocturia?
Thinning. Yes, ma'am. I did ask for nocturia. Nocturia, thinning of stream. Any thinning of stream, I asked, ma'am.
So he does not have any of these.
No, ma'am.
Okay. Okay. Can go with the examination.
Okay.
Out of all these histories for the urinary complaint which is there,
yes,
which one do you think the patient will be able to tell you first? Which he will remember, in fact, yeah.
So nocturia is most difficult for the patient to get up every night.
So nocturia is the most important. The patient will be able to tell you at the first instance. Yeah.
Yes.
Why did you take a history of smoking here?
So history of smoking for collagen, sir. For collagen, collagen muscular, it affects the collagen synthesis. Sir.
What happened?
So
how
smoking,
does it hernia?
So yes, the smoking itself it inhibits actually the two hypotheses, sir. One, it increases the collagen synthesis, but decreases the collagen phagocytosis by decreasing the action of fibroblast. Thus, it interferes with the structural, tissue structures, sir.
Mm-hmm. So if somebody is a smoker is there and another one is non-smoker, can it
Yes, sir.
change your treatment plan?
Treatment plan, sir.
Yeah.
It's not.
I will advise the patient to stop smoking.
Mm-hmm. No, but how it can change your treatment plan?
Treatment plan regarding smoking. Sir, laxity of the abdominal muscles, sir. So I will keep that in mind during my surgery.
What are the basic types of repair for a hernia?
The primary tissue repairs, sir.
Either it is a tissue repair or a
Primary tissue repairs or plug-in Gilbert's plug-in patch repair, sir.
or a mesh repair,
Or a
Any
mesh
type-
plastic, yes, sir.
any mesh plastic repair. So if somebody is a smoker,
Yes, sir.
what you will like to choose?
So I will prefer doing both herniorrhaphy and mesh plasty, sir.
Herniorrhaphy becomes a part of that, So you will always do a mesh repair.
Yes.
Whenever somebody is a heavy smoker is there,
Yes,
you will always tend to choose the mesh repair rather because
வந்து யாருன்னா நானும் இன்னொருத்தரும் அந்த இன்னொரு கனகவேல்னு ஒரு டாக்டர்.
Sir, Vivek,
அது வந்து இந்தியாவுல உள்ள எல்லா பெரிய பெரிய சர்ஜன்ஸ் எல்லாரும் வருவாங்க.
he has to be muted.
Vivek, please. Vivek, please.
எம்எஸ் படிக்கிறவன் வந்து பிரசன்ட் பண்ணுறேன்.
Vivek, sir, mute, please. Please, sir.
That is the importance of the smoking, okay? So if there's a heavy smoker is there, you have to always use a mesh for the repair purpose. Otherwise, you can also go for the tissue repair there sometimes.
Okay, sir.
Go ahead with your examination.
Hello.
Okay, sir.
Yes, madam. Yes, madam, please.
General examination, patient was well built, conscious, oriented, and affable.
Robin.
There was no. Yes, sir.
Kalevani madam is asking question.
Good evening, sir. Good evening, Srinivasan, sir. And
Please.
good evening, Ajay, sir. Sorry, I didn't wish you all.
Good evening, madam.
Yeah, sir. No, he was talking about treatment. I think when he's discussing about treatment after the case, I think I'll come back to it.
Yeah, madam. Good evening,
sir.
madam.
Yes,
Good evening,
madam.
sir.
I will add 2 or 3 points for the history. Robin, just go back 2 slides before. Just
Please.
quickly, I will tell.
Yes, sir.
Important thing. Go back. Yeah. Sometimes this lemon and watermelons are not accepted because it becomes a little fun in the examination. So don't stay small in size, gradually increase, not to have any problems. Now, only thing what you have written is it is progress to up to the scrotum. Can you tell what by up to the scrotum or what is it like?
So up to the scrotum, in sense, it is imaginating the scrotum, but it is not completely into the scrotum, sir, until the base of the scrotum.
So don't say base. There is no base of the scrotum. So you have to say one is the root of the scrotum, correct? So what you are trying to tell is it root there? Root?
Yes, it is onward patient, the onward I use, sir. That's why when I asked the patient also, he was able to tell the initial swelling was about the size of something. So he mentioned about the size of a lemon.
You are referring to the root means base or what is it? What exactly?
No, sir. Root means not the base, sir.
So they say that very clearly. So that is one thing. So because up to the scrotum means we have a little confusion there. Number one, of course, you are any violent cough anytime or weight lifting which have caused a rupture of the fibers because 65-year-old gentleman with only 3 months is as it happens.
Okay, sir.
That's one of the important things because you have written all the things there, chronic cough, etc., etc. Sometimes what happens is one kind of a strain sometimes carrying heavy loads. So all these people might have stress and might have caused a small rupture of the fibers, might have also give rise to small development of a hernia. Among all these things, which is all those no fever, why fever suddenly here? Why fever?
Sir, I was excluding inflamed hernias too, sir.
Don't come to those rarest of rare inflamed hernia and all that thing now. So it's
What
not,
is it? Now it means question, sir. What is inflamed hernia?
Correct.
What is inflamed hernia? Can you define?
Yes, from inflamed hernia, the content maybe a light appendix or mucus diverticulum, sir.
Which is inflamed, not just the presence of these contents.
Yes,
the contents
inflamed,
being inflamed.
Inflamed.
So
yes,
are you suspect? Is there any history of pain in the history?
No history of pain.
No.
history of
Then why are you expecting all these rare things? Don't invite such things. The entire discussion will go in that direction now. You are inviting a problem here.
Vomiting
Okay,
and
unless you want to rule out lymphadenitis, at least if you had said that, we could have accepted. But here the history is very clear. Reducible swelling.
What is the last sentence? No history of any other abdominal swelling. What is this other means? Why unnecessary? What do you mean by that? What do you mean?
No, sir. Any inguinal lymph nodes during any inguinal lymph nodes you would have palpated
Not
before.
inguinal nodes. Say that patient has no other swelling on the other side. That is important. 65-year-old man, if you suspect it's a bilateral, more common, because yes, you have written there to rule out prostate, etc. Is it clear?
Yes.
Right. Okay. Next slide. Next slide. Yeah, there's a everything is okay. I think can go ahead, madam. Yes.
Yes, sir.
General examination, patient was well built, conscious, oriented, and afibrilate. There was no pallor, icterus, clubbing, cyanosis, lymphadenopathy, or no pedal edema. Pulse rate was 78 beats per minute with regular rhythm, normal volume, and character. Blood pressure was 120/80 millimeter per mercury taken in supine position in right arm. Examination of the left inguinal region. Inspection. After obtaining proper consent, patient was examined in standing and supine position with adequate exposure from nipple to mid-thigh of the patient with adequate light. A single pyriform swelling of about size 5 cross 3 centimeter is seen extending from above and middle part of the left inguinal ligament down into the root of scrotum. The surface over the swelling appears smooth. Expansive cough impulse seen. Skin over the swelling appears normal. No visible scars or sinuses. No visible peristalsis. Right hernial orifice is free. No malgagny bulgings. Penis is in midline and scrotum appears well developed. Moving on to palpation.
Yeah, just show the picture for 1 minute so that we can, and then you can go for the examination. Right.
Palpation. Instructive findings were confirmed. There was no warmth or tenderness over the swelling. A single pyriform swelling of size 6 cross 4 centimeter is extending from above and medial part of the left inguinal ligament down into the root of scrotum just above the testis. Surface is smooth, doughy in consistency, expansive cough impulse felt. Swelling is reducible. On Seaman strains, an impulse was felt over the left index finger over the deep ring. On deep ring occlusion test, the swelling does not appear on coughing. Examination of the right groin, there was no scar, swelling, or cough impulse noted. Examination of the genitalia, penis was in midline, there was no phimosis. External urethral meatus is normal and adequate. No urethral strictures, and scrotum is well developed. Bilateral testis, epididymis, and spermatic cord appears normal. Percussion, there was dullness noted over the swelling. On auscultation, there was no bowel sounds heard over the swelling. Moving on to systemic examination. Per abdomen was soft, not distended. There was no tenderness, no fluid fluid, no organomegaly, and the bowel sounds were heard. Cardiovascular system S1, S2 heard, and there was no murmur. Respiratory system bilateral R&T was equal. CNS system, there was no focal neurological deficit. On rectal examination, there was no skin tag, sphincter tone was normal. There was no signs of any growth, hemorrhoids, or fissures. No prostatomegaly, and glow was stained with fecal matter in yellow. Coming to my diagnosis, left-sided reducible, indirect, incomplete, and uncomplicated inguinal hernia with probable content as amount seal.
Can we go back to inspection, doctor?
Yes, ma'am.
Yeah. What have you told over here? So your presentation of extent of the swelling is okay. You have mentioned as expansile cough impulse seen. You see the expansile cough impulse? For PGs, we shouldn't get into all these things actually. When is it expansile cough impulse?
Actually, in palpation, we can say expansile cough impulse.
It is only on palpation. On inspection, you'll see just the cough impulse. And why do you want to look for sinuses and scars?
Any sinuses and scars, I can rule out any other disease or a perforated viscous one.
You are suspecting perforated viscous?
No, not perforated viscous. Any other tract leading there? No, any sinuses tract.
What? Like what? What exactly? Be specific. Why do you want to look for sinus in that region?
Pardon me, not
What track? Again, see, again you're into trouble. You brought this sky sinuses unnecessarily. If the patient had come with a lymph node, you're suspecting a lymph node over there, then you talk about sinuses, it makes sense. You have a patient who says he has a reducible swelling, with reducible swelling in history, what will you think of? What is the diagnosis at the end of history?
Hernia.
Hernia. So why do you bring sinuses and other things unnecessarily?
Okay.
Okay. Then something else you told, I missed it. Sir, the other examiners can.
Rajagopal sir, Ajay Khanna.
You have done the rectal examination and you said there are no hemorrhoids. Is that a correct statement?
No, sir. No, there is no signs of any growth. Actually, I mentioned this at hemorrhoid. I mean,
You have written no hemorrhoids on your rectal examination.
No, sir, actually.
Leave that.
Sure.
Dr. Robin.
Yes, sir.
Robin.
Yes, sir.
So, sir wants to know, hemorrhoids can be felt or should be seen by proctoscope?
No, seen, sir. Actually, no. I instead of growth, I wrote hemorrhoids. I'm sorry.
So don't do that mistake in the examination. Okay. MS. My question to you is simple. This is a case of hernia in a male. My question is, why do you want to see expose him from the nipple to mid-thigh? Answer this question. Any specific reasons you have got or anything?
So I look for any other swellings also, or weak tone of the abdominal muscles.
No, not like that. See, abdominal examination, nipple to mid-thigh for reasons are, what are the reasons in a, let us say in a female patient? In a female patient, I've given you a clue. You want to rule out a carcinoma of the breast. And with the second is in the liver. Your case, MS exam case is mass in the liver. You want to examine the nipple when I say breast actually. That's what it means. You understand, no?
Yes,
and mid-thigh region is for men especially, you should not miss a testicular tumor or undescended testis.
Okay.
So what I'm trying to tell is, depends upon your case, you should decide. Okay? Because then they will ask you, why do you want to examine the, you may have to say,
sir, please, sir. Kalevani madam, konja mic la sound was.
You may have to say, Robin, sir,
yes, sir,
I examined the general physical examination. I have done the whole body, in which there may be a spider nevi. This is just to protect yourself in the MS examination, because patient may be alcoholic. Suppose they ask you, why do you want to expose his chest and etc. You may have to say, otherwise don't get into trouble. Abdominal examination I have done. Inguinal hernia, patient in the standing position. Enough. Say abdominal examination. You are already examining his genitalia, testis. So there is no other things are required. Is it clear to you? I hope it's clear. Okay.
Yes.
Ajay Khanna sir, you are unmute. Yes.
Is G-man test is a good test?
Sir? It is, sir.
Robin?
Yes, sir. Yes, sir.
Is G-man test?
G-man test?
The G-man test by other two tests, that is comparing to the other two tests, G-man test only for the femoral hernia and impulse we can denote from the G-man test. Sir.
The time it is
Robin.
Carried out.
Sorry, sir.
No, Robin. As Kanagwal sir said, you are using two systems. So the mic come back to one system. Yes, logged in. Robin, you can close one system. You stop the start.
Only one system is on now. Yeah, one is on.
One is enough, Robin. Yes, sir. Please.
One is.
Yes, Ajay Khanna sir, please.
Robin, what are the analysis of the deep ring of Can you hear me?
Yes, sir. Voice was not audible.
There is lot of noise is there. I think
மேடம் நீங்க மேடம் கொஞ்சம்
Sir, hello.
மேடம் கொஞ்சம் உங்கதுல தான் வருது
Even
மேடம்.
I am not able to hear.
You
Am I
off one device.
Yeah.
Madam, you can mute.
Laptop only laptop is on.
You can mute, madam, please.
Okay, I'll mute myself. Let me see.
Can you listen me?
Sir, now please, sir.
No, I was asking Robin, what are the fallacies of the deep ring occlusion test?
So fallacies, if it is a pantallus, whole ring cannot be occluded, sir.
Rajiv, sir, good evening.
Good evening, sir.
So one is you are improper occlusion of the deep ring. You have to use the thumb and give it forcefully. So that is one thing. And second fallacy is the deep ring will be more than your thumb. That is what sir is asking.
And if there is a pantaloon hernia, what is that pantaloon hernia?
A combination of direct and indirect hernia, sir.
So both the hernias are there, then that will be a fallacy of the deep ring occlusion test.
Yes, sir.
Robin,
Yes,
the
sir.
most important test, in addition to other than the expansile cough impulse and reducibility, is the deep ring occlusion test. That is the only test they will ask you. So now, can you tell me properly, how did you do this test? You tell me.
So first on supine position, I reduced the swelling, sir.
Good.
Then after occluding the ring, I asked the patient to stand.
No, 1 minute. I don't know where is the ring. Don't say I occlude the ring. You don't know where is the ring. So, yes.
Oh, okay, sir. So from the 1.25 centimeter above the mid-inguinal point.
I don't know where is mid-inguinal point. Yes.
So mid-inguinal point is a imaginary line from the anterior superior iliac spine to the pubic symphysis, sir.
Okay, just to cut it short, just say in the examination, I ask the patient to lie down. I reduce the swelling. If the swelling cannot be reduced, you have to try to reduce or ask the patient to reduce. Number one. If the patient cannot reduce it, there is no point in doing deep ring occlusion test. You can't say it is indirect or indirect. Just say I am not able to do it. Okay. Now the swelling is reduced. You run your finger along the groin crease. You know the groin crease between the inguinal region and the thigh. The first bony landmark you feel laterally is the anterior superior iliac spine.
Anterior superior spine.
Mark it.
Yes, sir.
Medially, the first bony landmark you feel is the pubic tubercle, but go to the midline. That is symphysis. Mark it.
Symphysis. Yes.
Draw a line. Draw, when I say don't draw it in patients with the black ink and all, I just want to tell you, select the midpoint of that and go half an inch above. This is the exact way you will tell. Okay?
Okay, sir.
Right? Because any other ways in which you can identify pubic tubercle, if this question is asked, can you say that?
Sir, along the tendon of the adductor longus, I can trace and identify the pubic tubercle.
Yes, it is a patient has to contract that tendon. Then only you'll be able to feel the tendon. With the bulky muscles in the thigh with the fat, it is difficult. So running your finger along the crease is ideal. So this is one test you should know properly, right? Okay. That's all from my side, sir. Please.
Where is the deep ring actually? What is, which muscle is it? Where is the superficial ring?
So deep ring is a defect in the fascia transversalis, sir.
What is the shape of it?
Oval in shape, sir.
The superficial ring?
So superficial ring is a triangular gap in the external oblique aponeurosis, sir.
Okay, it's an inverted V shape. Okay. Yes. What is the landmark for this superficial ring?
Just above and middle to the pubic tubercle, sir.
Raju, sir.
Sir, please, I have not heard the case.
Yes, madam. Now, okay.
Robin, have one more question, Robin. On inspection, you said the swelling is visible above the inguinal ligament. If I remember, what do you mean by that? Can you see the inguinal ligament, or it corresponds to something?
I meant by the inguinal crease.
And what?
By inguinal ligament,
what exactly you want?
And the inguinal. Sorry.
What do you want to rule out, basically?
Oh, I meant
Am I
the
audible?
inguinal crease.
Yes,
Both the
madam. Yes,
inguinal crease
you are audible,
swelling.
madam.
By
Robin,
inguinal
please.
ligament, I meant
What is the importance of the swelling above the inguinal ligament and below the inguinal? That is what is matters question. Is it right, madam?
Yes.
to differentiate below the inguinal ligament, I will think of femoral hernia, sir.
Okay. Fine.
Robin, you said that there's a expansile cuff impulse is there. Is there any other type of cuff impulse?
A transmitted impulse can be felt in varicocele. Sir.
Where do you get in the varicocele? Yeah.
Yes, sir.
Right.
Uh,
So,
Robin, how about impulse at the saphenous varix? What kind
So
of
it'll be
impulse
like
is that?
a thrill, sir. I can feel a thrill over the if the dilatation of the saphenous vein is
What
there.
is
I can feel a
Morris's
thrill.
cuff impulse then test? What is Morris's cuff impulse test then?
Morris's, sir.
Yeah, Morris's cuff impulse. So, like sir was Ajay Khanna sir was saying, there are a lot of cuff impulses, right?
Okay.
And so it's just not that it's in a hernia that this expansile and others it is transmitter something. It's expansile everywhere. So it's expanding.
well, what are the other swellings where you can get the impulse, cuff impulse?
So one is varicocele, saphenous varix.
Anything away from the inguinal region?
Cough impulse can be felt in any other swellings coming from the
He
intraperitoneal.
said away from the inguinal region. Where do you get the cough impulse?
Umbilical hernias.
We are leaving the
One
hernia.
more one.
Start with the hernias. Anything in the head.
You've named all the hernias. Anything other than a hernia?
Yes.
Robin, this question is apart from hernias. Apart from hernias, anything in the chest? Go above chest, neck.
Madam gave the hint. Chest. Thoracis.
Answer is solitaire.
Thoracis in solitaire. Yes, Kavi Prabha, you can answer if you know. Kavi Prabha, you can answer.
Okay, get meningoceles, you can get cuff impulse, you can get
meningomyelocele, sir.
Thorax, what is it?
Yeah, someone yes.
Empyema thoracis.
So basically, any swelling which is
the cuff impulse.
Any swelling having communication with the cranial cavity, with the thoracic cavity, with the abdominal cavity. So, peritoneal cavity. So, if you are given a young child with a dermoid cyst over the external angular dermoid here, this is an important test you should try to, especially younger children. It may have a small communication. Okay, so you should look for impulsum cough.
Ajay Khanna, sir, your question.
In the neck. Can you get any swelling in the neck with a cuff impulse?
A neck swelling
with a cuff impulse?
Pardon me the answer, sir.
Laryngoscele.
Laryngoscele.
Laryngoscele can have the cuff impulse. Right. Okay. Now tell various types of complications of a hernia.
So irreducibility, obstruction, and strangulation, sir. Can go into irreducibility, obstruction, and strangulation.
What is an incarcerated hernia?
So incarcerated hernia is irreducibility, and maybe the content can be the fecal matter as a content, sir, and with the irreducibility, sir.
With the fecal matter means liquid fecal matter?
No, sir. Solid fecal matter, sir.
Fecolith.
Hard fecal matter, you should say.
Hard fecal matter. Fecolith.
Now tell the classical example of the incarcerated hernia. Classical example of the incarcerated hernia.
Sir, right chest hernia, sir.
No, the left inguinal hernia.
Middle hernia.
Okay, when the sigmoid colon is there, and sigmoid colon has got the ficulis in that, and that obstruction is because of that ficulis. So that is a basic example of hernia.
Okay.
Now, can you get a strangulation without obstruction?
மேடம் உங்க மைக்ல இருந்தா மேடம் வருது. கொஞ்சம் மியூட் பண்ணுங்க மேடம் நீங்க.
Hey, mic, sir.
You can mute yourself.
Okay. Now instrument change. Shall I change the?
Yes, madam. You can go change and come, madam. Sir, you can proceed now. The disturbance is coming from. Yes, sir. Please, sir.
Tell the causes of strangulation without obstruction.
Strangulation without obstruction in right chest hernia, sir. Because in right chest hernia, only the part of the circumference of the bowel loop will be coming up, sir. So that can be impact blood supply over that side, and that will be patent intestine.
So that is one. Other causes. Other causes of strangulation without obstruction.
Umbilical hernia, sir.
What is the commonest hernia? What is the commonest content of the hernia?
Small intestine, sir.
Yeah, what is the commonest content?
Small intestine, sir.
Momentum.
Okay.
Yes, momentum coming there. So momentum is getting strangulated, but there is no obstruction.
Oh, okay.
Right? Then, any other?
Umbilical hernia, sir.
Mucus divertism column is coming inside. It is getting gangrenous, but there is no obstruction. Appendix coming inside the sac, becoming gangrenous, but
Yes,
no
sir.
obstruction. Okay, so all these are the causes of strangulation without obstruction.
Okay, sir.
Clinically, how do you differentiate between an obstructed hernia and a strangulated hernia?
So obstructed and strangulated, sir.
Yeah.
Sir, I'm not able to hear.
Yeah. Clinical difference between an obstructed hernia and a strangulated hernia.
So the strangulated hernia will be that will be tense and tender, sir. It will be tense and tender.
Patient with toxic, sir.
ఇవి ఎక్కడ ఉన్నాయి మొత్తం అరేంజ్ చేస్తా
కనగవేల్ సార్ కొంచెం మ్యూట్ பண்ணுங்க సార్ ప్లీజ్ మ్యూట్ ముత్తీశ్వరయ్య ప్లీజ్ మ్యూట్ yes sir please go on sir.
So in strangulated hernia the
how do you
it will be tense and
no you said how will you differentiate between clinically between strangulated hernia and obstructed hernia? You tell points number 1 and 2 like that.
Yes, sir. In strangulated hernia, the hernia will be tense and tender, so there won't be any cough and pulse, and there will be a recent increase in size will be there, sir. In obstructed hernia, the hernia need not be tense and tender, but there will be signs of intestinal obstruction like vomiting, colic abdominal pain, and abdominal distension will be there, sir.
So, in case of strangulated hernia, remember by many T's which are there. It will be tense, it will be tender, the patient will be toxic.
Tense and tender. Tender.
And the patient will also have the obstruction also.
Yes, sir.
Right? So all T's will come in that. While a case of obstructed hernia will only have the features of intestinal obstruction will be there. The swelling which may be there may be tense or may not be tense, usually not tense, and also not tender. Okay.
Yes, sir.
So you told the
Ajit,
2
sir.
points on tense and
Okay,
tender.
Robin, can you tell me which hernia has got the highest fatality rate?
Ma'am, I'm not able to hear, ma'am.
Which hernia has got the highest fatality? Fatal hernia, highest.
An incarcerated hernia or Spigelian hernia, sir?
Incarcerated is not, will not be. It is obturator hernia. Obturator hernias have got the highest fatality, right? because they usually go into when you have strangulation and gangrene, it is not easily discernible. You can't easily find out. Diagnosis is late.
Okay.
That is why.
Okay.
How do they
Madam.
present, Robin? How does obturator hernia present? What is the complaint?
Pain along the medial side of the thigh, radiating to the ipsilateral knee joint, ma'am. So the complaints will be there.
There is what is known as a house-shaped Romberg sign.
Absence obturator reflexes house-shaped Romberg signs.
Right. So when you internally rotate the knee, you get pain,
yes,
and there'll be swelling in the perineum.
Yes.
The pain is radiating to the knee joint because of
Genital branch of the genital femoral.
So it is the genital branch of the
Genital branch of genital femoral nerve, sir.
So these are the one which get irritated and you get the pain radiating. So that is has been described. The one of the reasons, most common presentation of obturator hernia itself is obstruction and gangrene. That's what Rajiv sir was telling. So that is why the mortality is also very, very high. If you are asked in the clinical examination, other than the impulse on coughing, reducibility and deep ring occlusion test, immediately after that, what other tests you should do?
Clinical tests, sir.
You mentioned about Malgagni bulging sometimes.
Head raising test and leg raising test I'll do, sir, to look for the abdominal tone.
What I want to remember is when you are inspecting the hernia, don't bring that suddenly Malgagni bulging at all, because you examine it separately so that you know I am looking for tone of the abdominal muscles. See, you are doing the inspection of the hernia first, then you are doing the palpation of the hernia. Then you are looking for that abdominal tone. Then abdominal tone is different from abdominal palpation. So tell me, in the abdominal tone, what did you look for? And in the abdominal palpation, what did you look for? Tell me.
So in abdominal tone, I asked the patient to lift his head and the head first. And then I asked the patient to lift his head raising test and the leg raising test I did, sir, to look for any bulgings, any Malgagni bulgings.
Don't say
And
any bulging. No. Either you go for a leg raising or head raising, doesn't matter. The same muscle contact, that is not the issue. Preferably for lower abdomen, you raise your leg, no problem. But where did you see the bulge? That is what I want to ask. Common mistake done by PGs. What did you see? Where did you see?
And what is that bulge due to?
Yes.
Yes, tell me. And what is that bulge due to? Which muscles?
So it is seen along the both iliac fossa, sir.
Be specific. Don't say iliac fossa now. We are not discussing abdominal quadrants now. We are in the inguinal canal now. Yeah, tell me. So, okay, not to waste the time. Common mistake done by everybody is to see the suprapubic area, rectal bulge, rectus bulge and all. No, you are looking for oblique muscle weakness. So, where are the oblique muscles situated? Laterally. So, laterally above the inguinal ligament. That should be your answer. Not iliac fossa and all. Now, we are not talking about abdominal quadrants. Okay, now what did you look in the abdominal palpation? Tell me.
So in palpation, I felt for any other swelling, sir, and cough impulse on over the other side of the hernial orifice
That is different, man. Again, don't confuse. Groin examination is different. Abdominal palpation is different. Palpation, you say, I ruled out any mass abdomen, especially left-sided colorectal malignancies are notorious to present with inguinal hernia because of increasing straining, constipation, poor muscle tone, elderly people. Okay. Left-sided colorectal. So in other words, any mass there. That's what. Yes, definitely you rule out a left hernia. Yes, madam. Please take over, madam.
Yes, sir. Robin.
Yes, ma'am.
So now a lot of anatomy has been discussed. Can you tell me the classification of hernias?
Yes, ma'am. Inguinal hernias, it is classified in 4 ways, ma'am. Inguinal hernias, anterior hernias, and posterior hernias and midline hernias, ma'am. So inguinal hernias is direct, indirect, and femoral hernias, ma'am. And posterior is superior Grenfell's and inferior Petit's hernia. And midline.
About the groin hernias, the classification of the groin hernias. Is there any name for the classification? It goes by somebody's name.
Oh, okay. NIHS classification, Gilbert and European Society classification.
What is NIHS classification, you tell me?
NIHS classification has 4 types, ma'am. The first type is the indirect inguinal hernia with a normal internal ring, and the second type is indirect inguinal hernia with enlarged inguinal ring. And the third type again has 3 subtypes now. The A, that is third type A is direct hernia. Third type B is indirect hernia with a sliding or scrotal hernia. Third type C is the pantaloon hernia. And 4 is the femoral hernia.
4 is femoral hernia. Okay. Is this classification important from your management point of view?
Ma'am, it was earlier few tissue repairs are being done for the first and second, but now it's not important. But defect size.
Yeah, defect size. Is there a classification for the defect size also?
Yes, ma'am. European Society gives the defect size also.
European Hernia Society also has given a classification for the size, isn't it? Okay.
Defect size, yes, ma'am.
Yeah. Is there any importance in relation to surgery? From what you said?
Sorry, ma'am.
No importance.
I'm not able to hear.
Is there any important classification on the management?
No, ma'am, not.
Not exactly. Okay, so now for this patient with 60-year-old man with a left-sided inguinal hernia, what investigation would you like to do? Tell me one important investigation you would like to do on this patient.
Ultrasound, ma'am.
Ultrasound of what?
Ultrasound of abdomen, ma'am. Sorry. Ultrasound of abdomen, and I'll look for the prostate size.
You have to look, though patient has symptoms or no symptoms, a 60-year-old man. Yeah, he may not.
I'll look for the prostate size. Yeah.
Yeah, what would you like to look for? Prostate size
and the prostate size and the other side hernial orifices or any other swellings, ma'am, or ascites.
That's important. What are prostate size and what is in relation to prostate you should look for? Is it obstructing or non-obstructing? So what will you look for? In the ultrasound, what will you ask for?
In ultrasound.
Have you heard of post-void residual urine?
Yes, ma'am. Sorry, post-void residual. Yeah, okay. Yeah.
What is the normal residual urine?
It? So what?
So more than 30 ml is considered significant, sir.
When do you say it's obstructed?
It is 60 ml.
60 ml, 60 ml. 60 ml. More than 100 ml, you have to take into consideration.
Significant.
Significant.
Okay.
So it is a must. This investigation is a must. Okay. Is there an indication for any other investigation on this patient? Would you like to do ultrasound of the groin?
Yes, ma'am. I will look for any other.
Hello, am I audible?
Yes, ma'am. You're audible.
That is a. If any case comes with inguinal hernia, you people ask for ultrasound of the groin, soft tissue scan to be more specific. Is it indicated in this patient?
Yes, from old age patient, and there will be lack of muscle tone. I look for another swellings also, ma'am, and especially the contralateral side orifices, hernial orifices.
Robin, suppose you find that it's an elderly patient and his PVR is 60 ml. What would be the next investigation you would do? In a patient with hernia, you got an ultrasound done.
I'll do, sir.
Huh?
Uroflowmetry.
Yes, you must do a urodynamic study.
Yes, sir.
Uroflowmetry. Okay.
So soft tissue scan is not indicated. So understand, soft tissue scan or MRI, all this is not indicated. These are indicated only when you're suspecting hernia or you want to rule out other causes. When a hernia is obvious, these investigations are not indicated because that has become the trend now with the younger students who ask for a soft tissue scan on all cases of groin hernia. So what do you say, sir? Shenoy sir and other seniors over here?
Ajay Ganesh sir, please.
I think it is not required until unless you are having some problem in that hernia, then it is okay. But otherwise, in an elderly patient, you definitely require to have the ultrasound. In a young patient, even that is not required. Or if it's an obese patient is there and you are not sure about that, then only in those cases you can go for this CT scan. But otherwise, for an uncomplicated hernia, probably you don't require the CT scan.
So that's what, sir. If there is a very big sliding hernia where you have a doubt, large hernias, giant hernia. Robin, what is giant hernia? Robin?
Yes, sir.
What do you mean by giant hernia?
So giant hernia, most of the content of the intraperitoneum will be in the sac, sir.
No.
Scrotal hernia, you mean, sir?
Obviously, scrotal only. At least half of the medial side of the thigh it should come. More than that. So these are the ones which you are called as giant hernias. They can have actually all colon, bladder, ureter, whole things can be inside. So these are definitely in such situations a CT scan is indicated. Otherwise, normally it is complicated hernias. And what do you mean by sliding hernia? What is the precaution as a surgeon we should know? Robin.
So now sliding hernia with the sac, part of the extraperitoneal tissue will be coming, sir. Most commonly left side of the sigmoid or right side of the bladder of the cecum, sir.
Correct, but be specific. It is the posterior wall. Posterior.
Posterior wall, sir.
So when you are, when you are twisting the sac, indirect hernia, you twist the sac and transfixation exercise, you may cut the piece of the cecum or sigmoid in your hand. One. Second thing is bladder. All large hernias, sliding hernias, catheterize the patient. More so bilateral, more so elderly, because they can always have a prostate with or without bladder involvement in that. Catheterization, one important. And clinically, when do you suspect sliding hernia? Tell me. Clinically.
So clinically, when swelling is difficult to reduce, I'll suspect sliding hernia, sir.
You cannot probably reduce the sliding hernia completely. When there's a lot of difficulty, giant hernias, you can't reduce it. Sliding hernia can be both direct as well as indirect. Both are possible. But then you suspect a sliding hernia. So this is a definite indication when you have that, to know that, so that you keep it in mind, so that you take precautions. That is the purpose. Okay.
Yes.
And just one question to you: by rectal examination, can you differentiate prostatic enlargement from carcinoma prostate? E65, short duration, 3 months history.
Sir, by the consistency or any nodules, I can.
No, you tell no. You have to tell no.
You have to tell when you put your finger, what will happen?
Exactly.
What will get obliterated? What will be the type of the surface? What is the consistency of the prostate? These three things you say.
Yes, sir. So the obliterated, the sulcus will be obliterated, so then the consistency will be hard, and the consistency of the prostate will be hard, sir. And there might be presence of nodules. I can feel for nodules in the enlarged.
So this is an important thing. You should keep it in mind. So in this patient, okay, prostate definitely yes, and in addition, carcinoma prostate is also a possibility. Examiners may deviate the questions for you. So that is the importance of hernia. Everyone knows it's simple case. So get ready to face these questions and answer. Yes, sir. Rajesh sir or anybody.
So you have to see also for the median sulcus. You have to say for the lateral cornices which are there. You have to see whether the mucosa is mobile over that or not. So these are the other things which you have to see for differentiation between a benign prostate and a malignant prostate.
Okay.
So you are planning for the surgery for this patient?
Yes, sir.
Okay. Now, how will you take the consent for the surgery for a hernia case? How you are going to tell all the things to the patient?
So first, I will differentiate into three things, sir. So in a layman term, I'll first explain my patient, but my patient is a farmer, sir. So I'll explain, and this is like a tear in the cloth. It cannot be stitched, glued or something. So it needs surgery. So if he's not undergoing a surgery, I'll tell about the complication that can occur, but not now, maybe in any stage. Irreducibility can happen at any time, in which case he may not be noticing about any pain, but irreducibility will be there, which can lead into strangulation. So I'll tell about the complications of not doing the surgery first, sir. Then I will tell him about the
inguinal hernia require the operation.
Yes, all the inguinal hernias. Yes, sir. All the inguinal hernias requires surgery, but reducible hernias can be posted electively later on, sir. It is not an emergency.
No, you answer to sir's question. Does all inguinal hernias require surgery? You have to answer this correctly.
Yes, sir. Yes, ma'am.
No, I think that is not a very correct statement to make.
Incomplete, we can wait.
If elderly patient is there with a direct type of inguinal hernia, which will probably never get obstructed or strangulated, probably you can leave that patient as such. It is not very uncomfortable to the patient. So all the hernias, majority, you can say the majority of the hernias will require the operation, but not all the hernias. There is a big debate which is going on that leaving the patient without operation and carrying out the operation with the post-operative morbidity which is there. And which is the most important post-operative morbidity nowadays which is taken care? Apart from the recurrence which is there, apart from the recurrence of the hernia that it can recur, what is the other next important morbidity there?
So chronic post-operative pains.
That is, what is that called?
Inguinodynia.
Inguinodynia. So that is a big debate which goes on about that whether we should operate all the patients for the hernia or not.
Yes.
Right. So this is in fact in the consent. That's what my main intention was, that in a patient inguinal hernia, when you are taking the consent for that, always tell the patient at least these two things, that the hernia can recur, and second, there can be a inguinodynia. What is the chance of having the inguinodynia after the surgery?
10%.
What are the causes of inguinodynia after surgery?
Nerve.
No, you cannot just like that say nerve. Which nerve? Please, Robin.
So iliohypogastric and ilioinguinal nerves.
Iliohypogastric is sensitive.
Ilioinguinal, there's two controversies from ilioinguinal nerve. Same book says ilioinguinal nerve, and few others says both the nerves. Ilioinguinal nerve most commonly.
The ilioinguinal nerve that comes in the inguinal canal, that is the one. How does it get involved? How does it get? In open surgery, get involved, you tell me.
This ilioinguinal nerve, this runs along the spermatic cord. So while resetting the spermatic cord, we may cauterize or transect the ilioinguinal nerve. That is the most common cause.
Cause pain. If you transect the nerve, will there be pain for the patient, or what will happen?
There will be paresthesium.
There will be paresthesium. There will be lack of sensation.
Yes.
When does inguinodynia occur?
Which part will be loss of sensation? In males and females. In males and females.
So the medial part of the thigh in females and the lateral part of the thigh in the males.
What? What did you say? Please come again.
Males and females.
No, it's the medial part of the thigh, sir.
Medial side in
medial side.
And males which part?
It's only the medial part of thigh or any other part?
And the gluteal region.
No. Madam, you can answer, madam. You can answer, madam.
So it is in the males, it is the medial part of the thigh, and then the skin around the root of the scrotum partially. And in the females, more important is the mons pubis and the medial part of the thigh. So the loss of sensation is important, to keep it in mind. And remember, the nerve involvement is in two ways. One is you cut it, there is a loss of sensation. It gets strangled in case of a suture or when the mesh can get inflamed.
Entrapment.
So the two reasons why inguinal occur. Okay, so
Okay.
their nerve doesn't get cut; it gets trapped.
Okay.
Okay, so while suturing, you should be very careful that you don't take a suture on the nerve. It should not get involved in the suture. And again, sometimes when the mesh is there, when it contracts, the size of the mesh reduces in due course of time. That can cause inflammation of the nerve, and they can get involved. And sensation, please go read. You have to be very clear on this, because if there's a young patient, all these things are very important. If you have to keep it in mind. Okay, and what's the nerve root value? Tell me, ilioinguinal nerve. It arises from where?
From the L1, anterior ramus of the L1.
L1. Okay.
Yes.
And please read about iliohypogastric. What happens if that is involved? And where does it come in your surgery, in the way of your surgery? Okay.
So the ilioinguinal nerve, once it enters the inguinal canal, before it enters the inguinal canal, it gives up the superficial cutaneous supply. So it enters the canal. That is why you injure it in the appendix, you are likely to get a weakness of the anterior abdominal wall. Whereas in the inguinal canal, if you injure, as Madam said, it's in the middle part of the thigh. Okay. So the root value is in one.
So Robin, that
Yes,
so Madam has already given all the details. She asked about iliohypogastric. So don't say in a routine thing, no. When you keep the mesh and try to fix her, at the upper portion, where do you suture the mesh in the upper portion?
the internal oblique.
Internal oblique, or what is that?
Arcing fibers of the internal oblique are transverse abdominis.
That is the time you should be careful there. That is the time where you can get that entrapment or whatever. So even genitofemoral also, this also supplies that. So these three can be cause of this. Any other complications? Ajay Khanna sir asked, the consent. Anything can happen to the testis? Very important.
Yes, atrophy of the testis can happen. So that I will include in my.
Due to what?
Due to injury to the vas, ductus vas.
Injury to the vas. I mean, don't do vasectomy. Don't do vasectomy.
RT to the vas.
No. It is actually, it's a vascular complication. Pampiniform plexus of the veins, when you handle, they can undergo thrombosis. Or by accidentally or without knowing, you cut the testicular artery. Testis may survive, but it will become smaller. So you should take, it's called ischemic orchitis. Okay?
Yes.
Ischemic orchitis, that word should come.
Yes, sir.
So it is mainly due to veins as well as artery. These are the two important complications in addition to the recurrence. And whenever you are using a foreign body, so whatever said and done, there is chance of infection. These all should be mentioned in your consent form.
One practical question I'll ask you, Robin. Hello?
Yes, ma'am.
Please, madam. Yeah. Please, madam. There is some disturbance coming from Lenovo. Lenovo, kindly mute, please. Sir, Kanagwal, sir, mute that. They are disturbed.
No.
Yes, sir.
Lenovo. Who is Lenovo?
Yes, sir. They are only keeping mic open and.
Okay.
Yeah. You off the mic.
Yes, Kanagwal, sir. Madam, you continue, madam. They open the mic and kill it.
Okay.
Question. You are trying to fix the mesh, and then as you are taking a bite on the inguinal ligament, you realize you've gone deep and your needle is in the femoral artery.
Yes, ma'am.
What will you do?
And first, I'll compress it and keep for a while, ma'am.
What will you do to the needle which you think
I will not take it out, ma'am. I will not take it out. I will not take the needle out. I will compress and keep for a while.
With the needle? With the needle?
I will take the bite. I'll take the bite, ma'am. I won't leave the needle. I'll take the bite and compress it, ma'am.
You will not take the bite. Okay? The moment you know the needle is take the needle out and then put compression. Okay? Don't try to, take a suture and try to ligate and then you'll think bleeding will stop. No, you're the femoral artery. You should never do that. I knew you. I expected this answer from you. That's why I asked you. Okay. Never try to tighten it and all. You should, the moment you know the needle has gone, take out the needle slowly and then put
And
pressure
compress.
to stop. Okay.
Okay.
Okay, fine. Any other questions? What is myopectineal orifice? Can you tell me?
Myopectineal orifice, the boundaries.
What is it?
It is
What is it?
it covers all the inguinal hernias, ma'am. So
Only
from
inguinal?
on the femoral, I mean.
So what is that area it covers? Which are the defective areas or the orifices that it covers?
Direct ring,
Tell the orifices.
superficial. Ma'am, deep ring, superficial ring, and the femoral ring. 3 rings will be covered in the
ring, the Hasselbalch triangle, that area. And
Hasselbalch triangle.
Okay. So what is the orifice called as? It's named after someone.
Fracture. Myopectineal is fracture.
Oh?
Fracture, ma'am.
Okay. This is more important when you are doing a laparoscopic repair. Okay.
Yes.
For the next,
decided for your
another 5-10 minutes, madam. 5-10 minutes, we'll wind up for the next session.
Yes, yes.
Kanaka sir is busy with
Robin?
Yes, sir.
What you have decided about your patient? What are you going to do?
Sir, I will do lichen stain tension-free mesh plasty for my patient, sir, for this patient.
You have got access both to the laparoscopic repair as well to the open repair. Which one you will prefer?
Sir, I am well versed with open techniques, sir. So I will give the patient, I'll give the option to the patient for both laparoscopy and open, but my choice for this patient will be open, sir. Lichen stain.
And suppose the patient wants laparoscopy, then he says, "I just want laparoscopy, nothing else." Then what will you do?
I will refer him to my senior who knows.
Right. Very good. You refer him to someone.
Robin, one more thing. See, there is in surgery in inguinal hernia, what is ideal and what you prefer to do. There are two things. So what is ideal for this patient? He has a unilateral hernia. What is ideal for him?
Ideal for this patient? Laparoscopy.
Laparoscopy? Now you tell me the indications for laparoscopic herniaplasty.
Any bilateral hernias or a small hernia without any complications?
Small hernias without complication is for you to learn.
Bilateral hernias, ma'am.
Bilateral
hernias. And previously open surgery.
Recurrence, femoral.
Yes, sir. Previously done surgery. So, yeah.
These are the three things.
Yeah, these are the 3 indications. So ideally for your patient, he has unilateral hernia. So what will you do ideally?
Total extraperitoneal repair is most.
Ideally speaking, for your patient whom you present is open lichen stains repair is the treatment of choice. Then it goes to surgeon's choice and patient's choice. Okay, this is ideal. So
Robin, you also keep it in mind as Madam has said, age of the patient also. Consider the age, comorbidity factor, cardiac illness, bronchial asthma, COPD. They are all contradictory to sometimes the general anesthesia. You should remember that. So you have to balance it out. It can be done even under local anesthesia, open method. You know that?
Yes, sir. Yes, sir. Yes, sir.
You should keep it in mind. See your patient, 70-year-old is having already cardiac compromised. So you keep it in mind. Okay.
Yes, sir.
Can we wait another 5 minutes, sir?
Ishwar was laparoscopic surgery.
Ishwar sir, good evening, sir. Ajay Khanna sir, your closing comments, sir, if can wind up, if you please.
No, sir, there are no standard guidelines. One is superior over. It all depends upon the institution where the patient is undergoing. And then particularly it is more useful when there is a bilateral hernia there, because the occult hernia is more than 3 to 4% if the patient is presented with only one side of the hernia. Bilateral hernia, younger patient always prefer with the laparoscopic surgery. Then it also depends upon the surgical experience also. We all know that laparoscopic hernia repair requires a long learning curve as compared to the open. So generally it is all left to the patient preference and surgeon's preference. Nowadays, a lot of literatures and studies have come. Both are equivocal. Sometimes it went to an extent to say that even laparoscopy is superior over the open. So the debate never ends. Debate never ends. Still goes on. But the only thing we can know that laparoscopy repair has got a long learning curve. It all depends on the surgeon. If the surgeon is expertise, then definitely one can definitely go for a laparoscopic repair.
So
Thank you,
Robin,
sir. Thank you, sir.
PG, for this case, you will say open Lichtenstein's mesh hernioplasty is the of choice. Okay?
Yes, fine, Lichtenstein.
That's what it
Yes,
should say. Don't tell meshplasty. There is no word called meshplasty.
yeah.
And hernioplasty.
Hernioplasty.
Okay? Please don't use that new term meshplasty. It's not there.
Okay, ma'am.
Ajay
Madam,
Kanasal,
Madam, even PG says that laparoscopy is still ideal. We can't deny it. We can't deny it. We have to accept it. We have to accept it. There's nothing like ideal, madam. Nothing like an ideal. Nothing like an ideal. There's only standard teaching. I do agree. But if the candidate, the student says that I would like to go out with laparoscopic, then you can't say no. That you have to accept it.
Sir, in a lighter way, the ideal husband, Charana.
Yes, sir. You're not going to listen to everything, no, sir?
Ajay Khanna, sir, please, sir.
We can close. Rajakana sir, closing comments. So we got one more comment. One more.
So just asking, what are the various nerves which you encounter during the open hernia surgery and during the laparoscopic surgery?
So open hernia surgery, I will encounter iliohypogastric, ilioinguinal, femoral nerves. And then laparoscopic surgery, I'll encounter 4 nerves. So that is femoral nerve, anterior cutaneous nerve thigh, lateral cutaneous nerve thigh, and genitofemoral branch of genitofemoral nerves.
Femoral branch, femoral nerve. Okay. Now tell when you are doing the open repair,
yes, sir.
Where do you get these nerves? Where you will get the ilioinguinal nerve?
Ilioinguinal nerve, it will be running along the spermatic aorta. So once I open the external oblique aponeurosis, I'll be encountering the
ilioinguinal nerve.
Sorry, sir.
When will be your first encounter with the ilioinguinal nerve?
After opening the external oblique aponeurosis, sir.
As soon as you are opening the external ring, that is the site where there is a maximum chance of injury to the ilioinguinal. So that is the site that the first encounter. Where do you get the iliohypogastric nerve?
Sir, just above the deep ring, most commonly I'll be encountering the iliohypogastric nerve.
You know, your mesh has to go at least 5 centimeters on the upper top. Okay.
Yes, sir.
So when you are towards the 5 centimeter side, then when you are taking the bite from the posterior wall, then you will encounter the iliohypogastric nerve there. Where do you encounter the genital branch of the genitofemoral nerve? And how do you identify that? Where it is? From the posterior side of the spermatic cord. And classically there is a blue vein which runs along with that. So by that blue vein you encounter, you know that this is the site for the branch of the genitofemoral nerve. Can you finish that, Dr. Srinivasan?
Yes, sir. Yes, sir. Please, sir.
Yes, sir. Kanna, sir, one more clarification. The nerves which are going to see in the open repair, they are never going to be observed in a laparoscopic repair.
Yes.
The nerves which are encountered in the laparoscopic repair were never encountered in the open procedures.
So, but what happens that whether it is iliohypogastric nerve or whether it is ilioinguinal nerve, they come from the retroperitoneal tissue there. Okay, when they are coming out of the lumbar plexus, they run in that area, and that is why if there is injury there, it can have the same thing as that of the open repair in the laparoscopic repair.
Yes.
Thank you, Robin, for your presentation.
Robin, you have any questions to faculties?
Kanavil, sir.
Robin.
Yes, mute sir. Sir. Please mute everyone.
You have any questions to the
disturbance from Jay Kumar, sir, Silvam, sir.
Please go ahead, sir. Please go ahead.
No, there is some disturbance from Jay Kumar that open mic.
That I will handle, sir. Please go to the presentation.
Yes, sir. We'll go to the next presentation, sir. If Vivek, sir,
Sir,
Robin, you can ask any question to the.
Robin.
So I thought somebody will come up with able to get about the swelling. I didn't mention about that. There was a very controversy for me to mention that, but I didn't mention in my slides. I thought there will be a controversy here. So I was about to ask about inguinoscrotal swelling and able to get about the swelling, sir. I didn't mention in my slides.
Robin, see, first of all, where is the swelling? Is it in the
Inguinal
scrotum?
region.
The inguinal region.
Inguinal region, ma'am.
It is totally in the inguinal region. Okay?
Yes, ma'am. Yes.
Question of getting above the swelling does not arise at all.
Okay, ma'am.
Okay? So the
Okay.
getting above the swelling is when the swelling is in the scrotum.
Scrotum, yes, ma'am.
So whether it's confined to the scrotum alone or going from the groin and scrotum, that is inguinal scrotum. That's what you have to differentiate. So here the swelling is in the groin, in the inguinal region. So this question does not arise at all. I hope I made it clear to you.
Yes, ma'am.
Okay. So when the swelling is extending down into the scrotum, then you talk about this.
Okay.
Otherwise, don't mention.
Thank you, madam. Thank you for the valuable comments. Ajay Khanna sir, with the permission, can we close and go to the next? Go to the next case.
Yeah.
Thank you, Robin.
Thank you, sir. Thank you, sir.
Kanavan sir.
So please go ahead, sir. Go to the next case, sir, please.
Yes, the next case is presented by
Kavi Prabha patient.
Kavi Prabha from Coimbatore Medical College. Please, Kavi
Thank you,
Prabha.
Dr. Robin.
Thank
Yes,
you.
sir. I'm sharing my slide, sir.
Yes, sir, please. Please.
Okay.
You made out share slides, Kari?
Yes, sir. I am trying to share my slides, sir.
Yeah, you can go. You should have brought it in.
Sorry, sir.
No problem.
Yes.
Close it. Close it, Microsoft Office.
Bring your presentation. Bring your presentation to the center.
Close
Yes,
that.
sir. Yes, sir. Yes,
Yeah,
sir.
now, yeah.
Yes, sir.
Go to slide share. Just put OK. Yes.
Sir, I am
Yes.
Dr. Kavi Prabha, final year postgraduate in Coimbatore Medical College. I thank Professor Dr. T. Srinivasan sir for giving me this opportunity and encouraging me to do this. My case, 60-year-old lady from Erode came with complaints of abdominal pain for past 1 month and yellowish discoloration of eyes and urine for past 1 month. History of presenting illness. She was apparently well 1 month back. Then she developed abdominal pain, which was intermittent, colicky type of pain, not a radiating type, which was aggravated after food intake and relieved by vomiting. History of vomiting present, which was non-bilious, not bloodstained, contains undigested food particle. She had more episodes towards evening. History of yellowish discoloration of eyes and urine for past 1 month. History of passage of black tarry stools 1 week back, which lasted for about 3 days. History of itching, which was present all over the body. History of loss of appetite present. History of loss of weight present. She noticed it by loosening of her clothes. No history of passage of pale color stools. No history of fever. No history of abdominal distension. No history of breathlessness, hemoptysis, cough. No history of headache, seizure, dizziness. Past history. She had no history of recurrent episodes of abdominal pain, jaundice, fever in the past. She is known hypertensive, for which she is on antihypertensive drugs for past 2 years. No history of any blood transfusion in her past. Personal history: she takes mixed diet. Her appetite was reduced, sleep disturbed, bowel and bladder habits normal. She is not an alcoholic, not a smoker, and no any other substance abuse was present. Obstetric history: she had 4 female children. She was sterilized. Family history: no history of any liver diseases, any other malignancies in any of her family members. Summarizing my case history: 60-year-old postmenopausal lady came with complaints of abdominal pain for past 1 month and vomiting containing undigested food particle for past 1 month, with yellowish discoloration of eyes and urine, with history of melena, and with history of loss of appetite and significant loss of weight.
Can add itching all over the body also.
Yes, sir.
Dr. Kavi Prabha.
Yes, sir.
Can you start with the first slide, please?
Yes, sir.
Yeah. Don't take it. I mean, one advice to you is that you have to write certain capitals. E road is a E capital.
Yes, sir.
Next page. Yes, S should be capital and all those H. First, please,
Yes,
because
sir. Okay, sir.
what happens is examiners look at your long case sheet, and when they look first time only, that impression should not be a wrong impression. That is the one. Now you said about intermittent colicky pain means what is the cause of this intermittent colicky pain?
Usually colicky pain is due to hollow viscous contraction against
in your case of you have written as it's obviously itching obstructive jaundice. In your case, what do you suspect with this history? What you have written there?
Sir, due to acute dilatation of common bile duct or biliary tree, it causes pain, sir. It is causing pain, sir. Which was
what is that? Acute dilatation. What did you say? Acute dilatation of the CBD causes colicky pain.
So due to stretching the nerve fibers will cause pain, sir.
I don't know. I'm confused a little bit. We generally say colic means yes, obstruction.
There is any obstruction to flow of bile.
So
there will be contraction of CBD, sir.
Typically, in your case, a 65 elderly lady with 1 month history of jaundice, itching all over the body, there is some passage of black tarry stools, there is significant weight loss. So what I'm trying to tell is you yourself should not contradict yourself. See, then the problem comes, or you should explain. So what I am straight away asking you is this CBD stones you are considering here?
No, sir.
So what
I'm
are
considering about malignancy only, sir.
So then how to explain that colicky, intermittent type of a pain, which was aggravated after food intake? So how to explain relieved by vomiting? So is there a way to explain?
Sir, she is having gastric outlet obstruction symptoms there.
So that is what you should try to say at the end, whether the findings match with your gastric outlet obstruction here. With 1 month short history, do you suspect there is so much obstruction? You have written there, history of vomiting, non-bilious. Means what? How many times she has vomiting every day? Is it persistent vomiting?
Sir, yes, sir. She vomits daily, sir, which contains undigested food particles, sir, for about 3 to 4 times, sir. It is more towards an evening, sir. It contains a...
So, madam, try to always understand the chronology. If the vomiting is due to, say, head of the pancreatic mass, jaundice will come first or vomiting will come first?
Jaundice, sir.
In your case, what did you explain first? Tell me.
I should explain Elias discretion first, sir.
You have started with the abdominal pain, then you started vomiting, then you have started with the yellow discoloration. So you try to understand your how should be the chronology, especially in your patient here, because it gives a different information for examiners. So I would have put it like this: yellow discoloration since 1 month, then no details about the yellow discoloration, persistent, progressive, fluctuating jaundice.
Yeah.
Is there any relapses, remissions? Nothing. You are not given there. Only
hey, sir, she told only Elias discretion, sir. She doesn't know about that progression and all like that, sir.
You should mention, no. Is it
yes,
progressive?
sir.
It has progressed to that extent, itching all over the body. She is unable to sleep. That means it is really a severe itching. We understand black tarry stool means there is some bleeding is there. So some fluctuation would have happened. So try to understand what I am talking to you. Chronology is, should be a little different way you should have presented. Okay,
yes,
sir.
I just want to ask, Kavi,
yes, sir.
You said that the colicky pain is because of acute dilatation of the hollow of the tube of the CBD.
Yes, sir.
Now in malignancy, you will not get acute dilatation. Malignancy is a slow procedure. It doesn't happen suddenly.
Yes,
you have come with the idea that this is a malignant case, but the patient's features are not of malignancy. If there's a stone, you'll have this kind of pain, you'll have this kind of vomiting, You may have jaundice, which can progress, but then you have, because they have not quantified the kind of jaundice, we cannot comment whether it's been waxing or waning, right? And loosening of clothes and loss of weight in 1 month, which I mean, CA head of pancreas is not that debilitating in 1 month, right? So your history is not corroborating with what you're going with, which is CA, right? So I have strong objections to this history leading you to come to the conclusion that is CA head of pancreas. We have to keep our mind open about stones. There can be bleeding also when there are stones. There can be erosion of the CBD because of stones, and that can lead to bleeding, or black tarry stool, right? So hemophilia is not just because of sloughing of the ampulla of Vater. In CA head of pancreas, we may not get, in CA head of pancreas, we will not get hemophilia or tarry stool. It is only in CA ampulla of Vater where we get this. So don't try to push in everything to make your case strong, right?
Yes, sir.
So let's go with an open mind and see what is the examination like. So like Dr. Raj Gopal said, quantifying and qualifying jaundice is very important.
No, I never heard that word, acute dilatation of the bile duct.
Yeah, I think
I never heard that word which is there, the acute dilatation of the bile duct. Okay, tell what is the difference between a waxing waning jaundice and intermittent jaundice?
Sir, in waxing waning type, the jaundice level doesn't come to normal, sir. The bilirubin level doesn't come to normal, sir. The intensity will reduce, but it won't subside, sir. In intermittent type, there will be disease-free period in between jaundice, sir.
Example of the waxing waning jaundice and give the example of intermittent jaundice.
Sir, what, sir? Sir, shall you
Give
repeat?
the example of the waxing waning jaundice. Example of the intermittent jaundice.
Sir, for waxing waning type of jaundice, it is seen in periampullary carcinoma, CBD stone, retained foreign body, T-tube biliary tract. In intermittent type of jaundice,
There's some disturbance. Ravindra Raj, please mute yourself. Ravindra Raj. Yes, sir. Please continue, sir.
for intermittent type of jaundice, examples are CA head of pancreas. Sorry, sir, it's a progressive jaundice, sir. It's a progressive jaundice, sir.
No, give the example of the intermittent jaundice.
Sir, intermittent jaundice is CBD stone, sir.
CBD stone, yes. Okay. Now, you have described so many types of pain. Now, tell what is the radiation pain, what is the shifting pain, and what is the referred pain?
Sir, radiation type of pain, the pain radiate to one side, sir, with pain in the original site also, sir. The example for the radiation type of pain, peptic ulcer, which erodes the posterior wall, which in this the patient have pain in epigastric region, and the pain is radiates to back in the same intensity, sir. For referred pain, the example is acute appendicitis, sir. In this type of pain, the pain, initial pain in the one region, sir, and then the pain refers to other side. At that same time, the previous pain was subsided, sir, due to the
It is some other type of the pain.
Sir?
The appendicitis, you get the referred pain or shifting pain?
Sir, shifting pain, sir. Referred pain is only referred pain. The organ is in different regions, sir, and the pain is felt at the different regions, sir. Example, shoulder tip pain in case of hepatic pathology due to the same somatic nerve supply, sir.
Cholecystitis, na? In
Yes,
cholecystitis, you get the pain in the shoulder region.
Shoulder region, sir. Shifting pain, the example is acute appendicitis, sir. Sorry, sir.
And in your history, you told about the patient is having the melena, but you have never mentioned about the hematemesis. Does the patient have the, because melena and hematemesis, they go together, jo hai.
Sir, in all situation, it won't be together, sir.
It won't be there, but once you're telling about the melena, you have to always mention at least so many no histories are there.
Yes,
And
sir,
that
there
is
is no
very
history of
important.
epilepsy. Yes, sir. Okay, sir.
Okay. Go about the examination now, yeah.
Yes, sir. General physical examination with proper consent. In well-lit room, I examined a patient with female attender. A patient was conscious, oriented, moderately built, and moderately nourished. Her vital signs: pulse rate was 80 beats per minute, noted in right arm radial artery, and then her BP 140/80 millimeter mercury, taken in right arm in sitting posture. Her weight is 56 kg and her height is 146 centimeter, and her BMI 26.2. Her ECOG score is 1. She is ectric. Pallor could not be assessed, and there is no pitting pedal edema, no generalized lymphadenopathy, no signs of liver cell failure, scratch marks seen all over the body. And then perabdominal examination inspection. Umbilicus was normally inverted, umbilicus not distended, no localized fullness seen, no visible pulsation seen, suprapubic horizontal scar of 2 centimeter size noted, no dilated vein seen, all quadrants moves equally with respiration, no visible gastric peristalsis, no visible pulsation seen, inguinal hernial orifice is normal. Palpation, no localized rise in temperature noted, all quadrant. Tenderness felt over the right hypochondric region. A well-defined globular mass of size 6 into 5 cm palpated over the right hypochondrial region and right lumbar region with smooth surface, well-defined margin, firm and consistency. It moves with respiration. Lower, medial, and lateral borders were palpable, and side-to-side intrinsic mobility was noted. I can insinuate the finger below the right costal margin. No other mass palpable. Liver not palpable. No splenomegaly. No renal angle tenderness. Percussion. Dull note was felt over the mass, which was continuous with the liver dullness. No shifting thrill, no fluid thrill, no shifting dullness, no fluid thrill. Liver span was 12 centimeter. Auscultation, normal bowel sounds here. No bruit or no venous hum over the mass. On auscultative percussion test, greater curvature of the stomach was just below the level of umbilicus, and succussion splash was present. Her pervaginal parietal examination was normal. No left supraclavicular node enlargement was noted. Examination of other systems, CVS S1 is 2 present, RS bilateral normal vesicular bed sounds present, CNS clinically normal. Summary: 60-year-old patient presenting with complaints of abdominal pain, vomiting of undigested food particle, elicitation of eyes and urine for past 1 month, melena history last for 3 days, 1 week back. On examining patient, well-defined globular mass felt over the right hypochondriac right lumbar region, likely to be gallbladder with a positive auscultative percussion test and succussion splash. My probable diagnosis: obstructive jaundice due to periamphic growth with gastric outlet obstruction probably due to duodenal involvement. And another differential diagnosis: carcinoma stomach with gastric outlet obstruction and portohepatitis causing obstructive jaundice.
You can.
Tell me, can you hear me?
Yes, ma'am.
Yes, madam. Yes, madam. Please.
Yeah. Can you show me the inspectory findings, abdomen?
Yes, ma'am.
Keep the mic at a distance.
Yeah. See, we are talking about the scar. Okay. Whenever you talk about the scar, you have to qualify the scar. Okay. Whether it has healed by primary intention or secondary intention. It's very important. One thing. Okay. Can you hear me?
Yes,
madam, please continue, madam. Very well.
So the other second thing is you should not equally with respiration. It is corresponding quadrants move equally with respiration. I just want to make these two corrections on inspection. Okay. So the rest is okay. Palpation. Can you go to palpation? Palpation. Yeah. You have started with no local rise of temperature. You tell me which abdominal condition there is local rise of temperature.
If there is any localized abscess that tracking to the abdominal wall,
okay,
it will produce local rise in temperature.
So something which is there inside and it will protrude to the abdominal wall, only then there will be local rise of temperature. So if local rise of temperature does not come, Understand? Until unless, as you said, the mass, what is the intra-abdominal roads into the skin. So if there is an intra-abdominal mass, how do they present? Sorry, intra-abdominal abscess, how do they present? Local rise of temperature or something?
Usually intra-abdominal abscess don't present with local rising temperature, ma'am.
Yeah, they are present fever in case they have to
Fever,
present with fever.
Fever.
So this point does not come. Understand? So in abdomen, you don't talk about local rise of temperature. Okay? Okay. Now going to the case proper. Now what is this mass you said is due to?
It is due to distal CBD obstruction and distension of the gallbladder, ma'am. The distended gallbladder, I felt.
The gallbladder mass. So why do you say it is a gallbladder mass? What are the points in favor of your?
It is situated at the lateral border of rectus, ma'am. At the lateral border of rectus and below the tip of the ninth costal cartilage. And then it is globular in shape, smooth, which has smooth surface, and it extends. It is situated at the right hypochondriac, and it extends to the right lumbar, ma'am.
Right hypochondrium, not chondrium. Okay.
Right hypochondrium and right lumbar region, ma'am, which has well-defined borders, ma'am. So
what is gallbladder point? You tell me.
Yes, ma'am. It is in right hypochondrium, and it is just lateral to the lateral border of just lateral to the lateral border of rectus, and it is situated just below the tip of the ninth costal cartilage, ma'am.
Which you explained. There's another way also which you can tell, where is some other line also passes, and that is called as.
It is in transpyloric plane, ma'am.
Okay, accepted. It's another line. It goes there. Yes. Anyway, you find out. I don't want to tell that. Okay. So, then now, what's your diagnosis? You said you made a first diagnosis of. Pardon?
My midclavicular line. You mentioned you asked for midclavicular line, ma'am. That line.
Okay. So tell me, what's the diagnosis? Why did you make this diagnosis? First diagnosis?
My first diagnosis periampullary carcinoma with a reodinal involvement that is causing gastric outlet obstruction, ma'am. Because in history, the patient is having vomiting of undigested food, ma'am.
No, wait.
It's slowly present.
Yes, we have to catch you then.
In history part, the patient is having vomiting of undigested food, and then the patient is having yellow discoloration of.
You're not audible, ma. You're not audible.
Yes, ma'am.
Hold the mic.
Am I audible, ma'am?
Yeah, now you're audible.
Yes, ma'am. With the history part, the patient is having yellowish excretion of eyes and urine, and patient is having melena, ma'am. It points towards periampullary carcinoma. The gastric outlet obstruction I mentioned due to the patient is having vomiting of undigested food particles, which is more toward evening. As the gastric distension with the food particle that vomits out, that the patient vomits out, ma'am.
These are the points you're saying are in favor of your diagnosis. But sir was asking, remember that.
It's about history, ma'am. On examination part, the patient is having a palpable gallbladder. It is seen in it mostly seen due to malignancy, ma'am.
What is that?
See, madam, Dr. Kavi Prabha.
Yes, sir.
When your case has got a palpable gallbladder,
yes, sir.
Why do you brought this carcinoma stomach with the porta hepatis nodes causing obstructive jaundice? When do you get gallbladder enlargement?
Sir, if the nodes in the region of porta hepatis got enlarged and it obstructing common bile duct,
so you get, is it porta hepatic nodes? You get an enlarged gallbladder. You understood where you got trapped now? The obstruction should be below the level of gastric duct joining the CBD, correct?
Yes, sir.
So then why do you want to unnecessarily get into trouble? So don't bring carcinoma of the stomach at this juncture. In this such a nice palpable gallbladder which you have described so nicely, you should your aim now should to find out why the gallbladder is enlarged. So where could be the obstruction? Can it be a carcinoma gallbladder? Any part of the gallbladder can give rise to a.
Yes, sir. If it is present in the neck of gallbladder, it may produce distended
At least it has got some value here. If you say could be there with jaundice or whatever, but don't bring carcinoma stomach with pyloric, portahepatis nodes.
Yes,
Okay.
sir. Yes.
And so I still feel you should be, your chronology of presentation from the history itself should have been proper. So
Yes,
then
sir.
only, otherwise what happens is this is what happens. You are giving more importance to vomiting and all that thing. So your line of thinking is going towards carcinoma stomach. You should have started from the jaundice. Has come down like that. Okay.
Yes, sir. Okay, sir.
What are the other causes of enlarged gallbladder? One is head of the pancreas or periampullary. It is due to back pressure. That's what you have written. Classical globular mass 6/5, all that thing.
Yes, sir.
Any other causes of enlargement of gallbladder?
Sir, in periampullary carcinoma, sir.
Oh, no, that is same. Okay.
Primary gallbladders, common bladder stones.
It is usually hardened, irregular, small contracted mass. Okay. Anything else? Okay. What type of gallbladder you get in mucocele? How do you differentiate? Mucocele.
Sir, in mucocele, the gallbladder will be tense.
Like this only, whatever. In fact, mucocele can be much bigger than this, but will they get jaundice? Will they have jaundice?
No, sir.
You should tell.
There is no jaundice.
Gallbladder without jaundice is mucocele. Alphabet gallbladder with jaundice is usually a lower obstruction.
Yes.
So hard gallbladder, tense gallbladder. When do you get tender gallbladder? Tender.
Sir, if it is empyema gallbladder, it will be tender, sir.
And just like an appendicular mass, you get a very vague inflamed appendicular mass in acute cholecystitis. Maybe with or without a small perforation. So clinically, you should be able to get some idea about it. Sir, Ajay Khanna, sir.
Now, in this patient, you said the patient has got the gastric outlet obstruction.
Yes, sir.
What one thing you have not demonstrated in this patient to say it is a gastric outlet? What one examination finding you have not demonstrated?
Sir, succussion splash, sir. And then
Splash is present.
Yes, sir. Succussion splash was present, sir, in this patient.
Any other examination finding you have to describe specifically?
Percussion test and visible gastric peristalsis, sir.
Yeah. So what about the visible gastric peristalsis here? Did you demonstrate
sir,
that?
I couldn't make it out, sir. Patient is little obese. I couldn't make it out the visible gastric peristalsis, sir.
We tell what are the various ways to demonstrate the visible gastric peristalsis?
Sir, visible gastric peristalsis, the peristaltic wave from the left to right in the gastric peristalsis, sir. The rolling movement.
If it is not visible as such, can you make it prominent by some way?
Sir, by giving water of about 500 to 700 ml of water, I can make it out, sir. But
okay. Any other way?
And then by flickering or tapping over the abdominal wall and then
and some people even say that you can put some spirit or alcohol over that.
Spirit or alcohol over there and yes.
Now, if you have to demonstrate the succussion splash as well as the visible gastric peristalsis, which one you will demonstrate first?
The succussion splash should be examined in empty stomach, sir. So I will examine it first, sir, and then I will ask the patient to drink some water, and then I will examine visible gastric peristalsis, sir.
Okay. Now, in this patient, you are saying gastric outlet obstruction because of periampullary carcinoma.
Yes,
how
sir.
common a periampullary carcinoma can lead to a gastric outlet obstruction?
So it's about 10%, sir.
And what about the pancreatic carcinoma, pancreatic head carcinoma?
Sir, mostly pancreatic head carcinoma that extend into duodenal wall, it will cause gastric obstruction, sir. Periampullary carcinoma, due to mass obstructing the duodenal region, that will cause the secondary gastric obstruction, sir.
That is, I think, probably too late to say that that is going to cause. So that is when the periampullary carcinoma, you hardly get the gastric outlet obstruction as such.
Yes.
But in carcinoma head of the pancreas, yes, you can definitely get that.
Yes, sir.
Ravi Prabha, I have one question to you. Between periampullary and head, which patients come first or early presentation?
Sir, early presentation is there in periampullary carcinoma, sir.
Why?
The The patient presents with melena, sir.
No, not Tina. The ampulla diameter is very, very small.
Putting the answer in your mouth,
So-
Kavi.
So what I am trying to tell is, because they come very early, it is very unusual to get gastric outlet obstruction. So your whole diagnosis, you see, you should think head masses. They present relatively late to the hospital with a large mass there. So you can explain more in that direction, not a periampular. Okay. Yes. But your case has got melena.
Yes,
So
sir.
you have got a lot of things in your presentation here.
Now tell Prabha why the urine is yellow in case of obstructive jaundice. Very basic question I always ask.
Yes, sir. In obstructive jaundice, the conjugated bilirubin will not be released into gut, sir. So it get absorbed into bloodstream, and then that will be excreted in the urine as dark yellow. That produce dark yellow color in urine, sir.
It is because of the bilirubin.
Yes, sir. Bilirubin.
Now what happens to the urobilinogen in the urine in obstructive jaundice?
Sir, it will be absent, sir. In case of obstructive jaundice, urobilinogen will be absent.
What is achondritic jaundice?
In case of hereditary spherocytosis or hemolytic jaundice, the unconjugated bilirubin level get raised, sir. It is excreted in bile, but gut also, sir. But it can't be absorbed, sir. So urobilinogen is not produced in the bloodstream, and then there is no color in urine or pale yellow color in urine. It meant as acaloric urine, sir.
No, go ahead with your investigation, keeping your diagnosis as a case of a periampullary versus carcinoma of pancreas.
Yes, sir.
Carcinoma of the stomach probably will not come because as
Okay, sir.
yeah, because once it's a metastasis, the porta-hepatis is there, you don't expect the gallbladder to be enlarged.
Okay, sir.
Okay, gallbladder enlargement will be only there when it is below the opening of the cystic duct.
Okay, sir.
Go ahead with your investigation.
First, as an extension of clinical examination, I will do ultrasound abdominal pelvis, sir, to know about the CVD dilatation, and then is there any nodal involvement, and then I will do.
You should see first the anatomical.
Tell all the findings of ultrasound.
Sir?
What are the various findings you can see? What are the various findings you can see on the ultrasound of the abdomen?
Sir, I can see dilatation of CBD, and then intrahepatic biliary radical dilatation.
Start from the liver, then go to the bile. Yeah.
Yes, sir. Is there any liver metastasis or any free fluid in the abdomen? I can see, sir, with ultrasound.
What you see in the liver?
Intrahepatic biliary radical dilatation.
What findings? Intrahepatic biliary ductal dilatation. That's the most important.
Yes, sir.
Right. Tell about the bile duct.
Sir, bile duct dilatation, if it is more than 8 mm size, I can see the dilated common bile duct, sir.
What is a double duct sign?
Sir, it is usually seen in the carcinoma head of pancreas, or the double duct sign is produced due to dilated common bile duct and pancreatic duct, sir.
What is the normal diameter of the pancreatic duct?
Sir, it is about 1 to 2 mm, sir.
Up to 3 millimeters. Okay. Up to 3 millimeters. Okay. Right. What you see in the gallbladder?
Sir, the gallbladder is distended, sir. In a case of periampullary carcinoma, sir. Distended gallbladder will be seen.
What else you can see on ultrasound?
Sir?
Can you see the pancreas on ultrasound?
Sir,
Can you see the pancreas on ultrasound?
Sir, it is difficult to see the pancreas in the ultrasound, sir, due to bubble gas in front of the pancreas, sir.
If it is a more than 3 centimeter nodule in the pancreas, can it not be seen?
Yes, sir. If it is a large mass, we can see it.
Yeah. The limitation of the ultrasound to detect the pancreatic head is if the smaller the lesion, less than 1 centimeter or 1 to 1.5 centimeter, the difficult to visualize on a sonography. 2 centimeter and anything and above could be made out by the sonologist most of the time.
Yes, sir.
Kavi, I think you've done a good job because the patient is having so many problems. But let's get back to this case now. So
Yes,
you
sir.
have a elderly lady, right? Present with jaundice, with obstructive jaundice, with a gallbladder lump,
Yes, sir.
and signs of gastric outlet obstruction. That's it. These
Yes,
are the
sir.
3 things. Now,
Yes, sir.
now how will you go about explaining these? Obstructive jaundice, how will you confirm that the patient is having obstructive jaundice?
Since the patient is having yellowish discoloration of eyes and urine, and then itching all over the body.
Right. So by history, itching, and then progressive jaundice, deep jaundice, with has she got with clay color stool or pale stools?
No, sir.
Right?
She is not having the pale color.
Okay, so that's rare also. So,
Yes.
and you can confirm by investigations whether she's got obstructive jaundice. Which other investigations you will do?
Sir, I will do CCT pancreatic protocol CT.
No. Hang on. You'll first try to confirm it's got obstructive jaundice or not.
Yes,
We'll
sir.
come to
I
that
will
later.
do LFT, sir. LFT to
Right.
rule out.
So you do that.
Yes.
Now we come to whether you saying that she's got a gallbladder lump. So
Yes,
we have
sir.
to confirm that.
Sir,
And
I
a gastric outlet obstruction. So
yes.
what will the next investigation will you do?
Rajiv sir, just to Kavi Prabha, in the LFT, just tell me quickly 2 things you say it is due to obstructive jaundice. It's better to ask them like that.
Right.
Sir, direct bilirubin level got raised, sir, and then
at least more than 50%,
and then ALP level gets alkaline phosphatase level gets raised, sir.
Okay, sir, proceed, sir, please, sir.
Right. So for your to confirm whether the lump is a gallbladder lump, and if there is any gastric outlet obstruction, what first investigation will you do?
Sir, I will do contrast and CT scan, sir.
No, you got simpler methods, please.
Sir,
Get an ultrasound, right?
Yes, sir, I will do.
So what will you look for in an ultrasound?
Sir, to rule out gastric outlet obstruction, I will see stomach volume, sir. Stomach gets distended in the gastric.
No, ultrasound is not a very good way of finding out gastric outlet obstruction. First, you'll see whether the lump is the lump is a gallbladder lump or not.
Yes, sir.
Right?
Yes.
What else will you see in the gallbladder?
Hypoechoic lesion within the gallbladder.
If there's any growth there or not?
Right? Is there any polyp in the
What else will you look for in ultrasound?
And then about intrahepatic biliary radicals, sir.
Very good. You look for the CVD, size of CVD, diameter of CVD, IHBR dilatation. What else? You just said you're looking for lymph nodes, isn't it? So you look for lymph nodes there.
Lymph node status, sir.
You look for the ecostructure of the liver, if there are any secondaries there.
Yes, sir.
Ascites, all that kind. A lot of things. Okay.
Yes, sir.
Okay. So you've done this, but you may or may not pick up any growth in the stomach.
Yes, sir.
Right.
Yes, sir.
So what will be the next investigation you'll do for that?
So I will do endoscopy, sir, to see any growth in the stomach.
And finally, which investigation will you round up all? Sorry.
Kavi Prabha, endoscopy. Don't say to look for carcinoma stomach in this patient. What is more important? What is your diagnosis? Periampullary. So now tell me endoscopy, quick. Yes.
Periampullary. For periampullary carcinoma, we can see with side viewing endoscope we can see the.
See, you know what you should tell is, sir, I will do a side viewing endoscope, and if the periampullary lesion is there, I will take a biopsy. Don't do the mistake of telling ERCP. Common mistake done. If you introduce infection means cholangitis, you have to drain it. So you say I will do a biopsy, minimum 6 pieces. And if you can't see a growth, what will you do? If the question is asked, There's tight stenosis. What will you do? I have given a clue. You can say yes.
Sir, if it is
You
by
can
the
even you can give a small cut there and try to take a piece of biopsy. Okay.
papillotomy. Yes,
So
sir.
you should then anyway when you are taking the scope out later you see all this gastric ulcer, pre-pylori. So please mention if you suspect periampullary carcinoma in the examination. After the ultrasound, you say I will do a diagnostic endoscopy. You
Yes,
can
sir.
get a biopsy and a tissue diagnosis. Okay.
Yes, sir.
Yes.
And if you can't get it, you can combine this with an endoscopic ultrasound. Okay.
Okay, sir.
Right. So
Yes.
that's, and then you finally wind up with which investigation?
Sir, I will do CECT pancreatic.
Oh,
with
you
the
will do a
pancreatic protocol, sir.
CECT. Right. So what do you mean by pancreatic protocol of CECT?
Sir, the pancreatic protocol CECT has 2 phases, sir. One is pancreatic phase.
It's got 3
Five.
phases.
5
3
phases.
or 5, you can say nephrogenic and delayed. 3 phases you should say. What are they?
Early arterial phase, late arterial phase, that is pancreatic phase, and then portal venous phase, sir.
Yeah, you tell the importance of all these 3. Sir.
Sir, in pancreatic phase or late arterial phase, we can see the pancreatic echo texture, sir. If there is any mass, we can made it out, sir. If the mass is hypoechoic, it meant to be adenocarcinoma, sir. If mass is hyperechoic, it meant to be neuroendocrine tumors in pancreas, sir. And then in late arterial phase, we can also make it out the arterial involvement, sir. The superior mesenteric artery and celiac axis involvement, sir, by the tumor. And then with the portal venous phase, we can make out veins involvement, sir, with the tumor. And then liver metastasis can be made it out with portal venous phase, sir. The liver mets can be seen as hypoattenuated lesion in portal venous phase, sir.
Okay. So suppose you find that it's a CA gallbladder.
Yes, sir.
At the neck of the gallbladder, which is pressing onto the CBD.
Yes, sir.
Causing jaundice. Right?
Yes, sir.
So how will you proceed with this patient now? No secondaries in the liver. Everything else is normal.
Sir, if the tumor is resectable, I will do extended cholecystectomy for this patient, sir.
So how will you know that the tumor is resectable?
Sir, if there is no nodal involvement, or else.
Now that you said, sir, the mass is pressing on the CBD, no? So that is causing jaundice. So how will you know it is resectable or not? It's based on that case.
So, ma'am, direct liver involvement by tumor is an contraindication for resection, ma'am.
But sir, what is sir's question? How will you know whether that is resectable or not? What are the findings? What investigation and what are the findings?
You can close the screen, Kavi Prabha.
Yes, sir.
No, first, is it operable or not? What are the signs of operability? That's what sir is asking. Madam has asked one question. Madam has given one clue. What are the other clues? Stop sharing.
Sir, I don't know how to
No, you
stop
close
sharing.
the screen. Close the screen. The screen. This cursor.
Goes to when it in that block of share screen, it will show us stop sharing.
Down here, stop share screen. You have stop share screen. You close this one. No problem. You keep answering. No problem. Don't. You keep answering. Yes, Ajay Khanna, sir, please.
Sir, the signs of resectabilities are in CAGB, CA gallbladder. There should be no metastasis in the liver, and then
Okay, tell what are the signs of unresectability in periampullary carcinoma?
ma'am, ascites, இது metastasis to liver,
Yeah.
and the viscerous node, supraclavicular node involvement, Blummer shelf. These are all the
about the end of the just which says it is not resectable.
if the superior mesenteric vessels involved involved multiple nodularity over the liver surface.
Okay, liver mets you already told. Don't tell that again and again.
Ma'am, superior mesenteric vein and portal vein confluence involvement, ma'am. Confluence of portal vein and superior mesenteric vein involvement is a sign of unresectability.
These are relative contraindication for that. Superior mesenteric vein confluence with the portal vein, they are relative contraindication.
More than 180 degree involvement of superior mesenteric artery, ma'am.
Superior mesenteric artery more than 180 degree, and then celiac artery, these are the absolute contraindication for a pancreatic.
Celiac artery, hepatic artery involvement, sir.
Superior mesenteric vein and portal vein confluence need not be a contraindication for surgery. With the help of the vascular surgeon, or you can put a vascular graft or a synthetic graft. One time they were considered as a contraindication for surgery, but nowadays with the surgical increase in surgical techniques, these are no more as a contraindication for a resectability. More than 180 degree superior mesenteric artery, celiac artery, these are the contraindication for absolute contraindication for the resection.
Yes,
local. I'm talking about the local involvement. Of course, what you mentioned, the distant signs of inoperability, they are there, like metastasis and other things.
Yes, sir.
Kaviprabha, you go to the top, you stop scare hearing Marumbar on the right side. Go to the top, take the cursor to the top, stop scares. Your screen.
Stop.
Okay, Kaviprabha, what we're trying to tell you
okay,
is...
you leave that, you answer the question.
Very carcinoma, isn't it?
Yes, ma'am.
You came totally prepared for that. What were the questions now? Sir asked, CA gallbladder.
Yes, ma'am.
Another surgeon, another examiner asked, CA pancreas.
Yes, ma'am.
And I got periampullary. So three of us are asking three different questions. So when you come prepared for a case, you have to keep in mind of all the differential diagnoses and don't read only one case and come.
Yes, ma'am.
So you should read about all the pathology in and around. Understand?
Yes, ma'am. Yes, ma'am.
Yeah. So here you understood what are the signs of non-resectability from CT.
Yes, ma'am.
You understood now? Very important.
Yes,
now what next? Now you find that CT everything is resectable. No celiac vessels involvement, no celiac nodes involvement, no liver mets. Now you plan to operate. What will you do?
First, if the patient is of hyperbilirubinemia, I will correct it first, ma'am, by stenting, by ERCP with stenting, ma'am.
When you want to do and what you want to do. Patient is having hyperbilirubinemia.
Yes, ma'am.
So what will you look at?
What are the corrections? Madam is asking, what are the corrections?
I will correct the patient nutritionally, and then hydration status of the patient. Hydration status of the patient should be corrected. And then if the patient is having low HB status, I will correct it also. And then I will correct the coagulation profile of the patient.
How do you correct the coagulation profile?
By vitamin K injection, sir. IM 10 milligram IM injection for the 3 days. I will correct it, sir.
Okay, what is the next thing, sir? When will you do this? Madam was asking. You asked other used to stenting, sir. Shana, sir, you can add, sir, please.
Yeah, nothing. Just Kaviprabha, if vitamin K after giving 3 injections, it has not improved. Where is the vitamin K produced from?
Sir, synthetic or phyto or plant, sir?
Prothrombin. Where? Sorry.
You can answer it, sir, please.
After vitamin K, if it doesn't improve, you have to give fresh frozen.
FFP, fresh frozen plasma, sir.
So what you should tell is first is hydration, definitely. You said nutrition. Can you tell me how to improve the nutrition? It's a little complicated chapter in this patient. This patient has been having vomiting, so you may have to. Yes.
Sir, endoscopic.
So I know
nutrition is also.
See, when a patient has got severe vomiting like this, there is only way to improve the enteral nutrition is putting a tube. Somehow you have to put a tube and feed distally.
Yes,
because you know that there is a periampullary lesion or a head of the pancreas.
Yes, sir.
You can't go on giving this patient TPN for long period of time. You understand now what I'm trying to say?
Yes, sir.
So if your history is correct in this patient has got vomiting since 1 month,
Yes, sir.
and you have got a head of the pancreas or preampular lesion. So nutrition has to be improved, hydration has to be improved, and then of course you have to decide about the plan now. Srinivasan, you can give a specific now. What is the finding in your case so that one can go? Is it preampular? What is it like?
No, sir. Ajay Khanna, sir.
Okay.
Take it, please, sir. Ajay Khanna, sir, please.
And yeah, in fact, if we know the diagnosis in this patient, then we can proceed better here.
That's what I asked Srinivasan, sir.
No, the patient was, sir, due to COVID, everything, we are not able to do it properly, sir. We get the patient, we examine, we before taking a CT, they go, sir, they stay in the hospital. We are not started a elective sir, because we are the surgeons.
Khanna sir, we will discuss it like periampullary carcinoma, sir. I think better.
Okay. Yes, sir. Khanna, sir, please.
Tell that what are the various ways to palliate the jaundice? Let us take whether it is a CA gallbladder or inoperable carcinoma out of the pancreas is there. Let us take that.
Yes,
so, what are the various ways to palliate the jaundice?
Sir, one way is by ERCP, sir. ERCP and stenting through the ampulla, sir, to relieve the jaundice, and then by percutaneous route we can decompress the biliary tract, sir.
So for this patient, how will you decompress? Which method? Percutaneous or you will do an ERCP?
Percutaneous method, ma'am. Percutaneous method only, ma'am.
Why not through the stomach?
So the patient is having obstructing growth, sir.
Yeah, you have difficulty in negotiating into the duodenum because you thought that it is a dilated stomach and there is obstructive element. Probably one may not succeed. Then we can go for the percutaneous drainage. Okay.
Yes, sir.
Okay. So that is one.
What are the methods?
Now, as a surgeon, how can you palliate the jaundice?
So you can palliate also her vomiting by doing something surgeon can do now. Yes.
To palliate the vomiting, I can prefer endoscopic stenting, sir.
No. Surgeon, we are Khanna sir asked
sir,
you.
gastrojejunostomy, sir.
Anyway, you are opening this patient for a surgical bypass or
by
whatever.
Surgical method, I will do gastrojejunostomy to palliate gastric outlet obstruction, sir.
And for the jaundice, what you can do? You open the
Colidocojejunostomy. Colidocojejunostomy, sir.
Colidocojejunostomy.
Or a hepaticojejunostomy.
No. This case, what will you do? You got such a big gallbladder. You do not know the CBD. What are the?
I think better you say triple bypass. Triple bypass include the food has to diversion, bile has to undergo diversion, and to avoid the food contents entering into the. If the CBD is grossly dilated, that is the better option. You understand?
Yes, sir.
Because if the growth, if you do a cholecystojejunostomy, what is the problem can happen? Can you tell me if the patient lives for say 1 year? They live longer sometimes. If you do a cholecystojejunostomy, future nodes can appear or a growth can spread and this may not function at all. Cholecystojejunostomy. So if you do a choledoco,
yes, sir.
Choledocojejunostomy, but technically difficult. Technical. I'm only talking. Best triple bypass. No, sir.
How can you decide that you can do a cholecystojejunostomy, which is relatively easier operation as compared to the hepaticodocojejunostomy?
Yes,
so
sir.
how can you decide that you can go for a cholecystojejunostomy?
Sir, if the proximal CBD also involved, I will go for cholecystojejunostomy, sir.
How will you know that? At operation, as a surgeon, you have to decide.
Sir, intraoperative ultrasound.
You can say, I do not know.
The intraoperative ultrasound, if you have got, yes, definitely. You do not have, you are working in a basic hospital, okay, where all these facilities are not available. Only
Sir, don't know, sir. Don't know the answer, sir.
Now, as a surgeon, you will put a needle inside the gallbladder.
Yes,
you
sir.
get a green pile there.
Yes,
then you can go ahead and do a cholecystogenesis. If you get a white pile there, which can happen, then you put the needle in the common hepatic duct. If you get the common hepatic duct green bile, but gallbladder is white bile, it means the cystic duct is obstructed. So you cannot use it for the polycysto bypass. But if you put the needle in the bile duct, in the hepatic duct, and if you get the white bile there, as well as the white bile in the gallbladder, probably you can go for the polycystogenosis. Okay.
Okay.
So it is the color of the bile which can decide. If you do not have any facility for the intraoperative cholangiography is not there, intraoperative ultrasound is not there, you can use this technique to see whether you can go for a polycysto bypass or not.
Yes.
Otherwise, definitely better is to go for a hepaticodoco bypass.
Okay.
Now, if this tumor is resectable, what is the surgery, preferable surgery?
Whipple's pancreaticoduodenectomy, ma'am.
Whipple's surgery. Whipple's pancreaticoduodenectomy. Okay. So you plan for a laparotomy. Then after laparotomy, what will you do? What will you see and what will you look for?
Sir, ma'am, I will look for any hemorrhage inside the, as a post-operative complication, I will look for any hemorrhage.
Post-operative? Intraop. I'm talking about intraop. You
Intraop
open
complication. I opened, first after opening the abdomen, I will look for resectability. I will check for resectability.
For resectability.
No, you have resected. Madam is asking after operation, what will you do? Is that the question, madam?
No, sir.
No.
You open the abdomen and then how do you decide whether you can proceed with Whipple's or not?
Yes.
I will check for the metastasis, ma'am.
Yeah.
Any tunnel?
Tunnel of love.
What is the tunnel?
If there is a clear space between portal vein and pancreatic neck, I will proceed with surgery.
In a lighter way, just a few minutes back, Ishwar Usmani told you involvement of the superior mesenteric and portal vein is no longer a contraindication. So, tunnel of love has landed diverse.
Online class.
So what I'm trying to tell is, it is
Online class.
you can mention, but you should be ready to say.
Yes, sir.
Online class.
Sir, I will check the encasement of SMA.
Live.
Kindly mute Denny's iPhone. Please mute.
SMA involvement of more than 180 degree, and then
which nodes?
Parayotic node involvement.
Celiac node.
The recent years, there have been a change in carrying out the pancreaticoduodenectomy. What is that change which is there? To tackle about this, whether you can make a tunnel or not. What you have to do before that?
Any maneuver, have you heard about any maneuver which you have to do just to expose the head of the pancreas?
Cattle brush maneuver.
Yeah.
You answer and get it there. If you are wrong, they are able to correct it.
Cattle brush maneuver, sir.
Cattle brush maneuver.
Fine.
So now there is an approach, what is called as superior mesenteric artery approach. First.
Yes, sir.
Okay. Superior mesenteric artery approach first, because it has been seen that if the superior mesenteric artery is involved, this is an irresectable tumor.
Yes,
so you have to go for that, and then you have to go for other maneuvers which are there.
Yes, sir.
Right. So what are you going to do? What are the structures you are going to remove in the classical Whipple's pancreaticoduodenectomy? Classical one.
Yes, sir. Head and uncinate process of the pancreas. First, second, third, complete duodenum with proximal 10 centimeter of jejunum, distal stomach of about 40 centimeter.
No. Stomach of 40 centimeter means the entire stomach. Tell exactly anatomically which part of stomach you stop.
Pylorus region, ma'am.
Antrectomy. It is antrectomy.
Yes, ma'am.
Pyloric antrum.
Pyloric antrum.
Antrum.
And antrum of stomach, duodenum, proximal 10 centimeter jejunum, common gallbladder, distal CBD.
Of course, head of pancreas you said the uncinate process.
Yes, ma'am.
Okay. So what is pylorus preserving? What is pylorus preserving, Whipple's?
Ma'am, in pylorus preserving procedure, we will leave proximal 2 centimeter of duodenum with it, ma'am.
Yeah.
This just distal to the pylorus.
Yes,
okay.
Now, how will you anastomose the pancreatic duct?
Sir?
What are the ways to anastomose the pancreatic duct?
Pancreatic duct. Pancreatico-jejunostomy or pancreatico-gastrostomy?
Yeah, that's what sir is asking. Pancreatico-jejunostomy. What are the methods of anastomosis? Isn't it, sir? That's what you're asking?
How will you anastomose the duct?
Pancreatic duct anastomosis, yeah. So you can do it with the jejunum, you can do it to the stomach. Then what are the various ways?
Yes, sir. I will create a opening in the posterior wall of stomach, and then I will take a stump of pancreas with the pancreatic duct, and then I will enter the portion of pancreas into the tunnel the portion of pancreas into the stomach, sir.
These pancreatico-gastrostomy, what you are telling, is ideal when you are preserve the pylorus. When you plan for a pylorus preserving pancreaticoduodenectomy, then
yes,
part of the posterior wall of the stomach is available to bury the stump of the pancreas.
Stump of the pancreas,
gastrostomy. When
yes,
you have done a classical Whipple's, that is pancreaticogastrectomy, most of the antrum has been removed. Probably posterior wall may not be abutting to the stump of the pancreas. In such cases, you have to go for the pancreaticojejunostomy.
Yes, sir.
So what are the various ways of doing pancreaticojejunostomy?
Don't know, sir.
She doesn't know, sir.
Okay, the most important one is the mucosa to mucosa anastomosis. Okay.
Okay.
So you have to carry out the mucosa to mucosa. That's the best way. But there are different types of the ink spot type of the anastomosis is there. Burying type of the anastomosis. There are different types of anastomosis. Okay.
Yes, sir.
What is the chance of pancreatic leak in pancreaticogastrostomy and pancreaticojejunostomy? Because that is one of the most important complications.
Yes,
pancreatic fistula.
Sir, it is about 10%, sir.
You need to read up all the complications. If you get a case like this, all these will be asked. That is, if you proceed and you come to this stage, all these questions will be asked.
You answer sir's question. What is the cause of pancreatic leak or incidence after the anastomosis?
10%, sir.
Yeah, it's around 10% is there, and it depends upon the expertise of the surgeon who is carrying out.
Yes, sir.
Okay, very important is the surgeon's factor which is there in that.
And now, getting the type of the pancreatic stump also plays a lot of role. If it is a fleshy pancreas, obviously.
Diameter of the pancreatic duct. Okay, all those things they come in picture.
Yes,
if it is a supple pancreas is there, it's more likely to leak. But if it is a fibrous pancreas is there, then it's less likely to leak. And then the diameter of that, if it is a very less diameter is there, a chance of stenosis as well as fistula is there. But if it is a big diameter there, you can make a good anastomosis.
Yes, sir.
Just getting back to the question, when will you stent the patient? At what level of bilirubin stenting will be done?
Ma'am, more than 50% of normal. More than.
Sorry, Madam is asking at what level of bilirubin is a cutoff point, whether to preoperatively you drain the system.
Preoperative stenting, right. Thank you.
You mentioned, no, you want to drain the CBD first. You have to.
Yes, sir. Sir, I don't know the exact value, sir.
Yes. 20 milligrams. Okay.
20, yes.
Above that, you can place a state. Below that, it's not necessary. You can go ahead with surgery.
Yes, ma'am.
Any other questions?
Jagannath, sir, please.
Sir, audio is not clear, sir. Hello, sir. Hello, sir.
Yeah, wait. Jagannath, sir, please.
Someone is asking you any question now.
Sorry?
Sir, you can ask, sir, please.
Okay.
Jailal, sir.
I was asking again the same thing, that what are the intraoperative ways to palliate the jaundice? One, we have discovered the polycysto or hepaticodocojejunostomy. What are the other ways to palliate the jaundice, like especially in the case of carcinoma gallbladder?
Sir, in the case of carcinoma gallbladder,
Do you know what
We
is
will-
segment 3 approach?
So type 3 approach. Segment 3 segment 3 has more delineatable bile duct in the surface, sir. So we can directly anastomose the bowel with in on that side, sir.
Segment 3 is one because the duct is superficial there,
Superficial layer, sir.
straight duct which is there. And that is why you can carry out the bypass from there, especially if there is a frozen porta hepatis. In a case of carcinoma gallbladder, you will get the frozen porta hepatis. That is the common cause of jaundice in the case of carcinoma gallbladder. So in those cases, you can go for that. And another technique which was described in the past was the Longmire's operation. You know what is Longmire's operation?
Sir, directly anastomosing left lobectomy and then directly anastomosing the jejunum over the right lobe, sir.
You can slice the left over the liver and the
then-
dilated duct which will come, you can anastomose to the jejunum. So
Yes,
that
sir.
is another way you can carry out.
Yes, sir.
What other thing you have to palliate in a case of carcinoma of the pancreas? One is the jaundice. Second is the gastric route obstruction which is there. And
Yes,
third
sir.
is the pain. So what you can do intraoperatively for the pain?
Sympathetic trunk sympathetic trunk block, sir.
Splanchnotomy.
Celiac trunk block.
Where you will do that? And what thing you will inject?
Sir, I can inject phenol or
Absolute alcohol sometimes.
absolute alcohol into the trunk, sir.
Alcohol in the, so you have to go around the aorta.
Yes, sir.
See for the celiac axis there, and then you can inject in that. So either you can do it just by feeling, or you can again go for the intraoperative ultrasound for that.
Yes, sir.
So these
One
are
more, even if the patient doesn't have a gastric outlet obstruction, whenever you plan for a bypass, prophylactic gastrojejunostomy is also advocated in the past, thinking that around in the future, around 30 to 40% of these patients will go for a gastric obstruction. Whenever you're planning for reducing the jaundice, at the same time, many of the surgeons they used to do even gastrojejunostomy prophylactically also, even though the patient doesn't having a vomiting.
Yes, sir.
You have any doubts, Kavi, you can ask.
Ajay Khanna sir, Jailal sir has joined. Jailal sir, congratulations.
Hearty
Ajay Khanna sir asked you.
Jailal sir.
Ajay Khanna sir asked for you, sir.
No,
Congratulations,
sir.
sir. Jalal, sir.
He may or may not join, but anyway, I'm happy he's with us.
Thank
Still,
you, sir. Thank you, sir.
I think we are happy to have the president as a faculty for our program. Thank you, sir.
Thank you, sir.
Vandona Ajay Khanna sir கேட்டாரு. Where is there?
I should put on.
Thank you, Ganna, sir. Thank you.
Kavi, I think, do you have any questions, Kavi Prabha?
No, sir.
Somebody in the chat box has asked the order of anastomosis, which you are. Please.
Kalevani, madam, can you take that question, madam?
Yeah. So first will be the pancreas. Okay, you should go in that order. The pancreas, and then next the CBD, and then the stomach. It goes in that order.
That is a very right approach for teaching the students, madam. But then the students should be aware that there are, it depends on what is the type of restoration your department follows. It's a single limb approach or two limb approach, whether you do a PG or PJ. So in order, if you're asking, madam's way is the right way, all the examiners will immediately agree. But then if you're doing very well, the examiner may probe you whether you do a PJ or you do a PG. And then the order little changes. Keep that in mind. But then madam's order is a common answer. Most of the examiners will agree. All right. Good.
That's for standard ripples.
Yes, madam. Yes, madam.
If the pylorus is preserving, we'll do pancreatic gastrostomy first, and then we'll go further later.
So that it becomes a more fixed part. So you finish that first, then you go for the remaining flexible anastomosis. That is all. Kanna sir, would you like to add something? Can we call it a close? Jailal sir, having come, I think you should ask a couple of questions to the candidate or teach with your points. You always have googly questions.
No, I have not listened to her. Whatever she has done well. I mean, I think it is good because you are all there, sir.
No, sir. It is every session is there. We are improving, and we get to have a different set of students' mindset. And I am sure none of the sessions are the similar, even though cases may be similar or anything. None of the sessions are similar. And I'm also proud to say we have crossed 5,100 subscriptions for official subscriptions. Of course, at least another half of them do not subscribe and they continue to watch. And still happy to share.
5,000 postgraduates, I mean, surgeons listening to that is a very great.
We have Saga sir with us, sir, from Bangladesh.
Sorry, sir.
Dr.
Pankaj
Saga
sir.
sir.
Yeah.
Sir,
Good
please
evening to all.
unmute yourself. Show up your video, sir, please.
He was there.
Saha, sir.
Yes, sir. Yes, sir.
Your comments, please,
Namaskar.
sir. Namaskar. Your comments, please, sir.
Yeah, thank you. I always enjoy this academic platform, always. Thank you very much. Proceed on, please.
Thank you, sir. Thank you. Sir, maybe we can have Bangladesh students also joining us sometime. We'll be happy
Yes,
to
sir.
have
Pass,
them.
sir. They can present also.
Okay.
Yes, sir.
Okay.
Vivek,
Thank
sir,
you, sir.
can we call it a close?
Yes, sir.
Yes, sir.
Yeah. You close it.
Congratulations, Kavi. Come prepared for all the diseases, okay, next time.
Thank you, madam. Thank you.
Physiology of Jaundice, okay?
Kavi, come up. This really a bold effort to have come here. So it is only a lot of learning.
Really?
No hard feelings. All of us have gone through this grilling. The earlier you get the grilling, you know where you stand and you catch up. And this is a positive note for you to work on where your lacuna is. Doesn't mean it's all learning. And we all continue to learn from you as well. Thank you, Kavi Prabha.
She just came back from the basket presenting, sir. She became a mother.
Oh,
and
very
she,
nice.
And she presented the first case. She came very boldly. Said, "You presented. They all will correct you. Nothing wrong. You be bold." She asked me to correct the presentation. I said, "No, they will correct themselves." And she came boldly. She wanted to present, so she is presenting.
Very good. Congratulations.
Thank you, madam.
Sir, coming forward and making an effort itself is a good sign.
Yes, sir. Yes, sir.
There is more important principle, coming forward and presenting. Mistakes can do